Good morning, everyone, and welcome to the Adults and Health Committee meeting here in Auchenbury on Thursday, the 13th of January 2022. I'm Richard Howard, the Chair, and welcome to everyone in the room and others who are joining us online. Just a reminder of the usual rules. We do allow filming and recording in the meeting, as long as it doesn't disrupt any of the business. We do ask everyone to make sure that your mobile phone is switched off or put onto vibrate. The meeting is indeed being live streamed, and a recording of the meeting will be put on the County Council's website afterwards. Can I just explain for everyone in the room, in particular, that we have been meticulous about safety for the meeting arrangements for today, in line with COVID guidelines. In order to protect ourselves and others from the spreading COVID, we will all be wearing our masks over our mouths and noses during the meeting, except when we are speaking. And I thank you for your cooperation from that. As you will see, we have a different layout of the room. It's reduced to be a maximum of 17 people. We're all at 2-metre spacing, and I promise you that technical experts have looked at the air conditioning and ventilation arrangements for the room, and that the numbers of people in the room for the space that we have and the ventilation we have clearly meet the scientific and health guidance that we've been given. We all know that there have been concerns about that, which led to the full council meeting being postponed, and so it's important to just accentuate that. And can I just say again, the government rules require us to meet in person, where it's not possible for councils to hold decision-making meetings in a hybrid or online way if we're voting, and so that is outside of our control. Also, in accordance with the Constitution, sorry, I will just take a break there because it's on that point. No, that's fine.
Thank you, Chairman. I very much welcome the efforts which have been made to ensure that we are all properly socially distanced, that we have proper air circulation within the room, and that we are minimising the opportunity for the spread of Omicron and of COVID-19. And I think that it's appropriate for us all to continue to wear face masks except when we are speaking. And I think that that is a completely correct thing to do. And I would encourage everyone to wear a face mask all of the time except when they're speaking. However, may I just get your confirmation as chairman that it cannot be a legal obligation for individuals to wear their face mask, at least for councillors, and a councillor may still attend and still participate and still vote, even if they do not wear a face mask, because there is no legal prohibition upon them so far as voting in attendance is concerned, just because they don't wear a face mask. As I say, I encourage everyone to wear a face mask, and I'll certainly be doing so apart from when I'm speaking.
Thank you. I'm looking at Tamar, but my understanding is that it's a requirement of the council by the council. It's not a legal requirement, but that we are saying that if we meet, these are the rules under which we meet, and I believe it's my obligation as the chair to enforce it.
Chairman, the councillors have a right to attend meetings under the Local Government Act 1972, and you would be infringing upon that statutory right were you to insist. And I say everyone should wear a face mask, and I'm certainly going to, and I'd encourage everyone to, but I fear that you would be potentially infringing upon the statutory right of a councillor to attend a council meeting.
His officer to send a message to the monitoring officer, because it's a legal point that's not something I think those of us in this room can immediately answer. It's a fair question, and we'll see if we can get an answer back from the I'm smiling because normally the vice chair and myself lean over and talk to each other, but our ability to do that is obviously slightly constrained today, which shows that we can do very serious things and have some humour at the same time. But to seriously respond to the point, if we'll send a message to the monitoring officer and hopefully get an answer before the end of the meeting, it'll help other committees as well.
Exactly. Thank you very much, Chairman. It won't be a problem with this meeting, I'm confident, but not everyone is a member of the Health Committee. Not everyone necessarily understands things the way that we do.
Councillor Murphy.
Thank you. I agree with requesting the clarification from the monitoring officer because it is a legal point, but just to note that health and safety at work legislation has changed now and includes communicable diseases. And so there are safety issues around that will be obligations of this organisation and indeed any organisation that allows members of the public or employees on its premises. So I think that there may well be some legal issues to sort out here.
Yes, and as I've already said, I myself feel bound by the rules of the council, and the council have instructed that the arrangements are the ones that I've announced. So if they weren't respected in the meeting, I would feel bound to apply them on behalf of the council, but it would be much better to get clarity as well with the legal opinion. So I don't disagree with the question being raised at all. I think it's the right to be raised. Thank you for contributing. I continue with my chair's introduction by saying that if we go beyond 2 hours, I'll seek to have a comfort break, but I'm also minded to try and make sure we have a proper lunch hour because we've got a full day's meeting and timed interventions in the afternoon from our invitees from the health sector. So, but I will endeavour to make sure we get all the breaks that we should do. There's no fire alarm test scheduled for today. If you hear the fire alarm, make your way downstairs as soon as possible, but in an orderly fashion. The muster point is in the green, on the green opposite the main entrance. Because of the limitation in the numbers of people that are allowed to be in the room, Charlotte Black and Tamar from Democratic Services are the only officers who are here with us, but the normal officer team that would be here with us, including Will and Jyoti, are present online, listening and available to take questions throughout the course of the meeting. So there's no difference with respect to that for any questions that any members may want to raise. And for the afternoon session, when we're joined by our district colleagues from throughout the county, they will be joining us, but joining us online in the way that happened at the last meeting. It's not ideal. I strongly would prefer them to be able to be in the room, but the room requires that to take place. And so that is the decision that we've taken. Councillor Bowden again.
My apologies for interrupting you a second time with your chairman's introductory remarks, but we have been told that we as members of the committee can also attend remotely in the afternoon. May I just have your confirmation about that?
Actually, I am happy that you've clarified that. Because this afternoon we're not voting on any decisions, if people want to jump onto trains, cars, taxis, or whatever other means, and you can get back by the afternoon, then you are fully able to join, and I will call you as normal. This is for any member, of course, if you chose to do that. It would be helpful to me if anyone's intending to do that, if they could just tell me so I can keep a special eye out on the screen for anybody who indicates, so that everyone is treated equally and fairly in the course of the afternoon session. But you are quite right to indicate that. Thank you for raising it. Longer introduction to the meeting than normal, but I'm sure people watching us will understand the reasons for that. We now move to item 1. Apologies for absence. We've got Councillor Bird, who continues to be on the road to recovery, and I've exchanged messages with her in the last period. And we have Councillor Boulat, who's joining us for the day on behalf of the Labour Group. You're very welcome to us, Councillor Boulat. We also have Councillor Hay, who sadly can't join us today, and I understand there's not a substitution for Councillor Hay, but we wish her well and look forward to seeing her next time. I'm now looking at Councillor Bowden again.
Thank you, Chairman. Could apologies be given for Councillor Clark for this afternoon's session, please, from Fenland District Council.
Thank you. Any other apologies that perhaps people know about? No, thank you. Thank you for that. We move on to asking if any member wishes to disclose any disclosable pecuniary interest or non-statutory disclosable interest for any of the business of today's meeting. There are none. I've got another introductory explanation, but an important one. So thank you for bearing with me. You'll note from emails that you received yesterday that an urgent decision has been added to the committee agenda and which was circulated yesterday and is published on the council's website. The decision is in relation to the allocation of adult social care Omicron support funding in response to the COVID-19 pandemic. Our constitution as a council allows an urgent item to be added to an agenda which has been published if it meets the urgency criteria set out in Part 4 Rules of Procedure, Part 4.4a. I won't read the provision out, but essentially I believe that this item requires us to respond quickly, and that the failure to do so would not be in the public interest and would harm the interests of the public, because this is about getting COVID money out there and used in the next days and weeks. That will be explained when we present the report. I'm completely convinced of that. Our procedures required me to speak to the acting chair of the council yesterday, which I did so and got his support. Thank you to Councillor Kindersley for giving this his due consideration, and therefore this report has been added after item 7 of the agenda. Again, I'll break there for any comment or question. Councillor Bowden.
Thank you very much indeed, Chairman. And whilst I don't have any problem with the agenda item itself, I am concerned that this agenda item wasn't sent to us until 4:20 yesterday afternoon. And if it is at all possible, it would be really helpful if urgent items could be sent earlier than just the evening before the meeting itself. Sometimes it's unavoidable, but if an urgent item is to be laid before us, giving us slightly more notice than that would be helpful. I appreciate that's not always possible.
Again, a very proper question, but just to say, I think we got the allocation of the money. Bearing in mind, I'm talking on Thursday at 10 o'clock in the morning. I think we got the figure allocating the money at 4 o'clock on Tuesday afternoon. The officers obviously had to consider that and consider the best way of dealing with it. They talked to myself and Susan, Councillor van der Ven, the Vice Chair, as early as mid-morning the next morning. We then had to go through a procedure, including consulting the monitoring officer and my conversations with Councillor Kindersley under the Constitution, and the officers had to write the report. That was completed by early to mid-afternoon, and actually it was a phenomenal achievement, I think, to get it out as early as 4:20 in the afternoon. What you say is, of course, correct, that the more notice would have been desirable, but I just place on record my thanks to our officers for, I think, acting very diligently and very quickly in the public interest, and I don't think in this case it could humanly have been done any quicker. That deals with that issue. We now move to item 2, the minutes, and we're asked to approve the minutes of the meeting on the 9th of December 2021 as an accurate record. They're on pages 5 to 26 of the agenda pack. Are there any issues that anyone wants to raise on the accuracy of the minutes? I see no objections, so we'll take them as carried unanimously. I now sign them. And I'll just leave them on the side there, and Tamar, you can pick them up later. Is that okay? An updated action log was also included in the published papers for this meeting. That's pages 23 to 25 of the agenda pack. Any questions or comments on the action log? Councillor van der Ven.
Thank you very much. And thanks to our officers for chasing the provision of NHS dental services in Cambridgeshire. This is enormously important, and it keeps coming up in a variety of conversations, just the impact of lack of access to NHS dental services. So I would just thank them and encourage a strong follow-up, and we're looking forward to receiving that. Thanks.
Yes, please.
Yes, if I may add a good reason to add to that, and thank you, and I also echo the thanks to the officers. Yesterday's meeting of the corporate parenting subcommittee brought up the issue of some of our children in care coming in and having difficulty getting their primary health checks, including dentistry. So I just bring that from the committee yesterday to add strength to what Susan has just said. Thank you.
Thank you. I think Kate Parker will be listening to the call. I see nods, so she will certainly be noting those two comments on behalf of the officer team. Thank you. Can we take the action log as noted? I see nods. My usual practice, if I see anyone shake their head, I have a vote. So don't feel constrained. If you do disagree, that's fine. And I'll see it and I would then take a vote. Item 3, we've got no petitions or public questions received. So we move beyond that item to item 4. We now move to the first of our strategic issues, which is the COVID-19 update. You recall after discussion at the last meeting, it was agreed that this is a standing item during the course of the pandemic for us. There's been a lot happening and once again, we're hugely indebted to Jyoti and her team for all the work they do on our report. And magically, Jyoti, you've appeared on the screen to my right, which fills me with huge optimism, and you're going to make a presentation to us. So Director of Public Health, Jyoti Attree, please.
Thank you, Chair. Okay, firstly, I'd just like to describe what's happening nationally, and you can see a dark...
Can you just hold for a minute, please, Jyoti, if you're hearing me. Is there any way the volume can be turned up at all? Because it's slightly low in the room. I'm just looking and seeing if will that be heard? It will. Okay, so technical support outside the room will have heard that, and we hope that can take place. So if you could just now continue, Jyoti.
Okay, thank you. Sorry. You can see a very dark map there on the right-hand side of this slide, indicating that rates are high up and down the country, and actually the scale doesn't do it justice. The rates are well over 1,000 and even up to 3,000 per 100,000 in parts of the country. Whilst if we look at the numbers testing positive, it appears that there's a bit of a dip. I would urge a bit of caution in interpreting that, because what we've seen over the Christmas period is variations in behaviour with people seeing more people, socialising more, seeing family, etc. But also changes in testing behaviour, with a dip on Christmas Day and over the New Year period, but peaks in testing uptake on the 29th of December and the 3rd and 4th, coinciding with the return to schools. So what we're seeing is a bit of inflation in the numbers testing positive, and then a drop back down to the mean. And as we move forward, we've also now got the change in requirements for the confirmatory PCR test, which will also impact on the numbers testing positive, because it's likely that not all positive LFTs are being reported. Deaths within 28 days are also rising, as are the number of patients admitted across the country. This graph here is just demonstrating the point I've just made about variations in testing uptake. This is now moving on to the rates that we're currently seeing, and as of the 4th of January, we were seeing rising rates across all of our districts for all ages, and also the over 60s. across the districts, they are generally below the East of England average and the England average, with the exception of Huntingdonshire, which is above the East of England average for both all ages and over 60s. Now, these are very high rates. These are rates that we have not seen before. And I don't think we're quite near the peak yet, because we are seeing a steep incline. But also, if we look to areas that are slightly ahead of the curve than us, London and the Northwest, rates reached levels as high as 3,000 per 100,000. So I think we've got more to come. This is showing the trend over time. The little dip that we see in Cambridge is likely to do with students returning home and coincides with a drop in testing rates in the 20 to 25 category. I think, the thing there to be particularly concerned about is the rising rates in the over 60s, who we know are more vulnerable to severe infection. And these are very high rates for our over 60s. If we look at variation by age category, I don't know if can you see my arrow?
We can.
You can, okay. So this peak here is in the 10 to 19-year-old category over the autumn term, and is likely to be driven by Delta. This is Delta here. Rates have dipped as we've headed towards Christmas, and we've now started to see a gradual incline with a slightly steeper incline in the school-age population in the last week. This is Omicron here. This is what we're seeing. And because of the higher transmissibility of Omicron, I would expect that to continue to rise pretty steeply. So before Christmas in the autumn term, the rates were largely driven by the school age population. That has changed over Christmas, and rates are highest in the 20 to 39 categories. But we are, as I mentioned earlier, seeing rises in the over 50s and in the over 80s. So there's been a bit of a change in the epidemiology leading up to Christmas and over Christmas. Pre-Christmas, driven by the school age population and Delta, now shifting to the young adult population, but also likely to impact on school age population as we move through the coming weeks. And that is, Omicron is our predominant variant at the moment. This is showing hospital admissions. The very high peak is the January peak that we saw in 2021. We are now starting to see increases in our hospital admissions. The ratio of cases to admissions is much higher now. So there are much higher case numbers, but a much lower ratio of admissions now compared to the January peak. But again, I would urge caution in interpreting that, because we have yet to see the full impact of the rise in over 60s rates on hospital admissions. There's usually a 2-week lag before we see the full impact of that. And we've yet to see the full impact on deaths as well, because then there's a further 2-week lag before case rates start to impact on death rates. And I think the other point to make is, so there's a couple of other points to make. Firstly, that those rates reflect people coming in who have they've come in for other reasons, but they've come in with COVID, because community rates are high. It includes people who catch COVID in hospital, and it includes people who come in because of their COVID. But the other point to make is that whilst rates aren't as high as we saw in January, there are other issues to consider. The particularly high community transmission rates are impacting on workforce absence. And as I showed you earlier, this is largely circulating in the young adult working age population. Anyone with COVID in hospital causes additional pressures in terms of infection and prevention control measures being needed to be applied. So these rates need to be considered in the round of other issues that are also impacting on pressures in hospitals. Our death rates remain pretty static, with 9 deaths in Cambridgeshire over the last 28 days, 18 deaths in Cambridgeshire over the last 28 days. But as I said, I don't think we've seen the full impact of our rising rates in the over 60s on hospitalisations or deaths yet. Some positive news to share with you. Rates of booster keep continuing to go up. I can confirm that we did hit our target of being able to offer all adults a booster vaccine before the 31st of December. And in fact, there were vacant slots should people have wanted to take them up. And in January after Christmas, we are continuing to see not as rapid a rise as we saw in December, but a steady rise in rates. Our rates are higher than England and the East of England average for all of our districts, with the exception of Cambridge, which continues to lag about 6 points behind. The data cleansing exercise that normally happens in October has not happened yet, and I think that is partly what we're seeing here, and you'll see why I think that in a moment. This is showing uptake of first doses. And again, I think this graph gives us cause for optimism. Whilst Cambridge City does continue to lag behind England and the other districts, we are continuing to see an increase in the uptake of first doses. So I think our efforts in terms of vaccine hesitancy are paying off and are worth persevering with. This is showing the school age vaccine uptake, and we aren't seeing the gap for Cambridge here that we are seeing for the adult population, and that to me indicates that this could be a denominator issue, and cleansing the lists may make a difference to that. So just to talk a little bit, if I can stop sharing, about what we're doing about all of this. We did have our ERA enhanced response area status up to Christmas. It ended on the 24th of December. The measures that we were applying through our ERA status are now largely available to us via the government's Plan B. So I don't see any merit in continuing to apply for ERA status. I think we have seen some of the benefits of the Surge Rapid Response Team, as I demonstrated earlier, that our rates have continued to increase, including first doses. And I'm just looking to see where they were over the period before Christmas. So, find my notes. They were in Wisbech, Huntingdonshire, Camborne, and Cambridge City in the lead up to Christmas. And I think the fact that first doses have continued to increase does provide some evidence of the effectiveness of that additional support that we received. Vaccination, I think, is still the mainstay of our response to COVID, and will support our protection of vulnerable people and prevent hospital admissions and deaths. We continue to manage outbreaks in care homes where we know we've got the most vulnerable people. We haven't seen large-scale outbreaks as we did in January, and again, I think that's indicative of the impact of the booster campaign in care homes. But we continue to keep a close eye on that and manage outbreaks in care homes. And then schools, I think, are the other area. Whilst children aren't at higher risk of adverse outcomes, if classes are sent home or schools have to close, it does have an impact on the wider workforce. So we continue to, rates will increase. We won't be able to stop them, but if we can manage them a little bit and try to avoid sending kids home, or at least whole classes, I think that will help to support the workforce, our NHS staff, our key workers, to keep working. I'm happy to take any questions you may have.
Thank you. If I can give guidance to members, if you can, it's only advisory, but if you can keep to about 2 minutes maximum, that will help because we are already running behind, but this is an important issue. Anyone like to start? Councillor Bowden.
Thank you, Chairman, and my apologies if it might be slightly longer than 2 minutes, but I've got some serious issues to raise. It has turned out, as had been guessed, and I'll use the word guessed because too many things which happen in advance are guessing rather than working on knowledge, but has been guessed back in December, Omicron has turned out to be far more transmissible than previous versions of the virus, but has had less serious consequences on average. And this was a reasonable guess to make in December, but it wasn't certain. And I was disappointed that that likelihood hadn't been reflected in the way in which we had approached the forthcoming few weeks that we had over Christmas and the New Year. The ratio of cases to admissions at the moment, or at least last week in the area, is very interesting. Whilst 3 times more people today, last week, were testing positive in our area than was the case 12 months ago, 3 times fewer people were being hospitalized. And if you want to have a very crude measure, and it is a very crude measure, I have to say, you're talking about that ratio of cases to admissions being 9 times less serious now than it was 12 months ago. And the reason for that is overwhelmingly obvious. Quite apart from the inherent greater weakness of the Omicron variant, the real reason is vaccination and boosters. And what I would really ask, I agree with the Director of Public Health entirely that vaccination has to be the mainstay of our response. That was the word she used. I don't think she's entirely correct. So I'd emphasize, if at all possible, could we please get that message out, redouble the message, vaccination, vaccination, vaccination. And let's redouble our efforts both on social media and also in the press releases that we put out. Can we please just, when I say up our game, I don't mean increase the quality of our game. Could we increase the quantity of our game, please, so that we try and get that message across even more clearly to as many people as possible? We know when we're looking at the numbers that unfortunately hospitalizations and even more unfortunately deaths are very much lagging indicators behind infections. The pattern has been very clearly established over a long period of time, and that pattern looks as though it's going to continue in the future in the next few weeks. And we can therefore expect that so far as hospitalizations and highly regrettably deaths are concerned in our area, we are going to face worse times in the next few days and weeks before we see better times, which is deeply, deeply regrettable. Of course, every single death we're talking about is an individual and there's family involved, and we should never allow the numbers to get in the way of appreciating that these are human beings, that these are individuals that we're talking about. But again, the comment which was made by the Director of Public Health, which is quite correct, is that London and to a lesser extent the North West are almost leading the way here. They're telling us where we're going to be going. And there's no reason to believe that there will be a massive difference in the profile of the curve between what happens in London and the Northwest and what happens in the rest of the country. It's just that some of us are a little bit behind that curve. So it's actually useful to look at the numbers in London and the Northwest, and we can see where we are going on this. And that's why we can anticipate that we're going to get some worse news before we get better news, but the better times are coming, and it looks very much at this time, based on the data that we've got, that we are going to find ourselves in a stronger position in a few weeks' time than might have been expected previously. So I think it's very important that we put across a more balanced view when we do put across the message. I want that vaccination message to be absolutely predominant, of course. But it's important that we put across a balanced view and point out the relative positives as well as the negatives when we are putting our messages out to the public. Because if we get the reputation of being all doom and gloom and of presenting the worst case scenario at all times, we will potentially lose credibility. And we may need credibility for the future. It is actually important that we prepare for the worst credible scenario. That's a prudent and appropriate thing for us to do in our public health function. But that's not to say that we necessarily broadcast that as being the likely scenario. And the reason I'm concerned about our credibility for the future is that I'm sorry to say we don't know if there are going to be any future more serious variants of COVID-19. We're not necessarily over the worst in the COVID-19 epidemic. None of us knows that. Absolutely no one knows that. And it's possible that there is going to be a future variant which is going to be even more transmissible or substantially more serious in its effects, which will have a much more devastating effect upon us than we've seen before. It's possible. I'm not trying to scaremonger. No one knows. Now, eventually, we're going to have to learn to live with the deadly COVID-19 virus as it becomes endemic, just as we've learned to live over the years with the deadly flu virus, which has been endemic for a long period of time. So that's going to be where we're going to be aiming for, and we're going to have to prepare for that. But my biggest concern is we must maintain our credibility as being a reliable source of balanced information, so that if the worst happens, and let's pray that it doesn't happen, but if something much more serious happens in the near future or in the next year, let's just hope that we are in a position that people believe what we say and they don't think that we are overemphasizing the problem, because it's possible that we could have much more serious problems in the future than we've had in the past. Thank you, Chairman, for indulging me.
Not at all. It's a carefully prepared and thought out presentation, which I agree with. I think if we talk about credibility, though, it's a pity that you didn't refer to other members of your own party and who have cast such doubts on credibility.
As a point of order, Chairman,
it's a shame that you didn't do that.
Sure. As a point of order,
what point of order into the Constitution do you want to raise?
My point of order, Chairman.
What is the point of the Constitution you want to raise it under?
That there is a responsibility of all members.
What's the number on the Constitution?
I don't have the number, my apologies, but Chairman, you really should.
It's not a point of order then. It's not a point of order.
Before party
it's not a point of order.
Nor is it a point of behaviour.
Councillor Slatter, please.
A quick question. In the light of another of my grandchildren getting positive, but fortunately her parents being working from home, she's primary school education. I would be interested in Jyoti's views on whether we can press the government for the allowance of children younger than 12 to be vaccinated. Some of those are, of course, secondary school pupils. There are fewer of them now than last time I asked that question. But I'd be interested in your views in terms of the children, because clearly they are a source of infection and positive results, even if not bad symptoms, fortunately. A response to Councillor Bowden, I absolutely agree with you. I fear that I, like most of the people in this room, not the sort of role model that is likely to have much effect on the ones who are resisting or hesitating to have vaccination. But I absolutely agree, we all need to have conversations. And if anybody who have ever had a breakthrough in changing somebody's mind, please share it, because that's the sort of thing that officers are trying to pick up on in terms of conversations with the vaccine hesitancies, if you have any. It's one by one, as you say, it's one by one the deaths, but also one by one the vaccinations. So let's all have a go at that.
Thank you. Councillor Boulat, please.
Thank you, Chair, and thank you for welcoming to the committee today. I'm really pleased to be here, especially as a lot of the issues on the agenda relate to CYP as well, which I'm a member of, and it's good to have this collaboration between the committees. I would like first to thank you for the update and for all the work and the efforts of officers and, of course, Director of Public Health, because I often feel that we do, obviously it's our role to scrutinize and to ask critical questions, but often we don't hear some positive comments as well. So thank you everyone for what is a huge effort on this Omicron variant. I had a few constructive questions. First, I was wondering if we can have a little bit more insight into which groups we should prioritize in the immediate weeks and months in terms of communications about the vaccine, for people to come forward for the vaccine, because I understand that a lot of both the local and the national comms at the moment has rightly focused on the booster, but I'm particularly interested to know more about what plan is in place to encourage those who are still yet to come for the first dose. And I noticed there is a slight increase in those coming forward for the first dose, but still in our region, it's a bit below the England average. So what more can we do on this, on encouraging the people who are yet to have their first dose to come forward? Also, I remember some discussions in previous meetings and some briefings where I asked some questions about the data as well, on how to best inform, especially newer communities in our county about the vaccine program, including, of course, migrant and refugee communities, and in particular, those who don't have any experiences of the healthcare system in the UK, because there's a lot of misinformation, especially on some, online groups in terms of people who never used the NHS before, not really knowing how to access it or what healthcare rights they have in this country. So could you let us know, please, if there's any progress on this, on the groups that are less likely to engage with the health system in the UK in general? How can we better engage those communities in the immediate weeks? And also one final question, what kind of factors in your view explains the lower uptake in Cambridge City compared to the other areas, please? Thank you.
Thank you. Next, I have Councillor Murphy, please.
Thank you very much, and thank you for the really excellent presentation. I've just got a couple of questions really about the data. Appreciating London is ahead of us, but it has a different demographic and a different sort of vaccine profile, age profile, etc. But in terms of this slight sort of uncertainty about the number of cases versus the death rate, is there anything we can infer from the London experience that can help us prepare here in terms of the death rate? And linked to that is really, is there anything in the serious illness hospitalization data of people who are there with from COVID? Is there anything about being unvaccinated versus vaccinated? This is a question, obviously, personal risk with Omicron, it seems to be lower than with Delta, but population risk of the impact on health service and other life systems obviously is very high. So we still have to be very mindful of it. I'm just interested if there's a little bit digging into the data for London, whether there's anything more we can learn.
Thank you. Councillor Howell, please.
Thank you, Chairman. Chairman, first of all, I want to congratulate how well we've all done with regards to the vaccinations. It's very, very good to see it. We're above the English average and also above the East of England average. And on that, I just think we should be, we are concerned. There are people there not vaccinated for whatever reason, but we should also be praising us, and we should be the main point of contact. And that's the information we want to get out, that we are the main point of contact for this area. Other groups do nationally or other regions, but for Cambridgeshire, we are the main and should be the priority source. And as though we all got concerns about this vaccine, this particular variant and other variants that may come along, at the same time, we should congratulate ourselves and those people who have made the effort to have that and try and protect us all.
Thank you very much. And I wholeheartedly agree. The next person I have is Councillor Gay.
Thank you, Chairman. I preface my remarks by stating that I'm not speaking on behalf of the Joint Administration or indeed the County Labour Group, but rather in my position as a Cambridge University professor and active researcher in immunology and virology. As I understand it, the severe restrictions under which we are forced to meet today, and which also caused the suspension of our democratic processes with the cancellation of the full council meeting in December, are as a result of a risk assessment carried out by the Director of Public Health in response to the emergence of the Omicron variant in early December. At that time, I wrote to Dr. Attry pointing out that there was already significant evidence that the Omicron variant is substantially less pathogenic than its predecessor, both as a consequence of its inherent properties and the prevalent high levels of cell-mediated immunity in the population. Dr. Attry did not dignify me with a response, but informed her assessment using modelling projections which have proved to be overly pessimistic and also groupthink amongst the public health community. 5 weeks later, it is clear that the threat of Omicron is very much less than Delta and Alpha. And even though hospitalizations have increased, maybe half of these are admitted for other reasons and have or require COVID incidentally. So COVID admissions at the moment are not that much higher than the 1,000 or so per day that are expected with viral pneumonia at this time of year in a normal winter. In this circumstance, what I would like to ask is when there is going to be a revision of the risk assessment that imposes the restrictions that we are currently under, and what specific conditions will trigger that reassessment, and what kinds of information will be fed into that new risk assessment, including the emerging consensus amongst virologists that COVID is in the process of becoming endemic. The second issue that has arisen out of the measures taken in December, which I am concerned about, is that it was stated to me by a number of people that the County Council has a duty to protect people who are unvaccinated and people who are immunodeficient. I find this very difficult to understand because immunodeficiency encompasses a huge range of different conditions, ranging from very serious things like severe combined immunodeficiency through infection with HIV to transplantation. And these individuals are not uniquely susceptible to coronavirus, but to a whole spectrum of different pathogens. It seems to me really impossible to provide guarantees that people who are immunodeficient can be protected by the County Council, but rather they need to act on the advice of their physicians and take appropriate actions to protect themselves. So I would like to hear responses to those 2 points. When are the risk assessments going to be reevaluated? And what is the legal position as far as protecting the unvaccinated and the immunodeficients? Thank you.
Thank you. Just to say, obviously, our Director of Public Health is one of the senior officers of the Council. I could have intervened there because I think this is about emails and communications aren't properly dealt with at committee, but I think the questions are very valid questions, and I'm sure the Director of Public Health will answer those questions in her summing up. Councillor van der Ven.
Thank you, and thank you very much, Jyoti, for your presentation and your work. And I just wanted to pick up on your mention of the good news on the take-up of the first dose, and really to say thank you to the team, which I know has been working very closely on a one-to-one basis, and also to thank Councillor Villatte, to agree with her question on, just getting into more detail on the groups that still have vaccine hesitancy and what we can do there. So thank you.
And Councillor Wilson, please.
Thank you, Chair. I've just got myself caught up in my glasses. A number of comments which I've got have been raised already, so I'll just concentrate on one thing that hasn't been. Does the County Council have a role in encouraging people to wear masks in supermarkets and other venues like that? And if so, what is it and what should we as individual councillors do? And just picking up on the vaccine hesitancy point, I think that there is still a significant number of people who have not been vaccinated. And whilst we're doing a tremendous amount of work, I think we still need to think about what else we should be doing to get those people vaccinated, and whether the main reason that they're now beginning to come forward is because they recognise that they've got to have some sort of vaccine passport to go on holiday or to go into nightclubs or whatever. Thank you.
I think that's everyone. Just a couple of remarks from myself. Firstly, the point about the press and communications efforts that Councillor Bowden raised. I think Matthew Hall from the communications team again is listening online to and watching all of our proceedings. Those messages will have been heard. I just want to assure everyone in the committee I'm regularly briefed as is the Vice Chair on the efforts, and it is pretty non-stop and pretty impressive. So I believe that everything is being done that should be being done there, and commend all of those responsible. I think from Jyoti's presentation, the issue that I would want the public to hear from this debate is that Omicron is not near its peak in Cambridgeshire, and there's fatigue about listening to these messages. I think that's been said by some in the debate, but it's the responsible thing for us to conclude from this morning's presentation, and it will be into next month before there could be any chance of rationally, properly and responsibly being able to lift any messages that we would wish to put about the need for safety and precaution and following all of the guidance meticulously, whether people are fatigued or not. That is the responsible thing for us to say, and that's what the figures that the Director of Public Health have shown us. I am pleased that the enhanced response area that the Director of Public Health applied for has been successful. Let's just hear that we've done something as a county council that has actually made a difference, a marked difference in terms of vaccinations, and I congratulate everyone involved. And I hear what is said by the Director of Public Health in terms of children, and I just want to place on record, I regularly talk with Councillor Goodliff, the Chair of Children's and Young People's Committee, about this, and I know Jyoti briefs her and the colleagues there as well, and the efforts that are taking place by all of our education colleagues who work with the Children and Young People's Committee, working with schools and head teachers, are phenomenal. Thanks very much to everyone involved in school life, because a lot of the impact at this stage of the pandemic is with them, and they deserve our great thanks. I think we should note the fact that probably the biggest impact at the moment is in staff absences in the health service itself and in other vital services, with people either having the virus or having to isolate because of it, and that itself is producing huge strain. And the last conclusion I hear from the presentation and debate is that the vaccination rate is continuing to go up. So even if there's some fatigue with the messages, they are working, and that should give us confidence that we should carry on with those efforts, not alter our efforts in that respect. So Jyoti, thank you so much for your presentation, but also listening to all of those points. We look forward to your responses.
Thank you. There was an awful lot there, and please do come back to me if is there another question?
No, it is for you to speak now, please.
Yeah, okay. Please do come back to me if I omit anything. So firstly, to respond to Councillor Bowden's points about did we overreact? We acted in line with the evidence being collated on our behalf by the UKHSA, and at the time there was uncertainty about the severity of Omicron. And that is the message that I was giving at the time. There was absolutely concern about the higher transmissibility and the potential harm at a population level that higher rates could cause to a population. And I think we acted proportionately and to reduce risk that we were uncertain about at that time. So what else was there? I think there was a question about London and the Northwest. I think, yes, it would be foolish not to look at what's happening in areas that are ahead of the curve than us, but there are some differences, particularly in London with a younger population. And the fact that we're behind the curve has given us some advantage in that we have been able to get many more of our population protected through the vaccination programme. So whilst we do need to look and learn from what happens in areas that are ahead of the curve than us, it's unlikely that we will follow exactly the same pattern for those reasons. I think there was a question about vaccination in young people under the age of 12. That's a matter for the Joint Committee on Vaccinations and Infections to consider. And immunisations to consider and make a declaration on. They will be keeping that under constant review, and it will be informed by the actual potential harms to people under 12 and the benefits to them. And they have to consider the benefits and harms for the people who actually receive the vaccination, as well as the wider population. And at the moment, they have not considered the benefits to outweigh any harms. There's some questions about the risk assessment that was carried out prior to Christmas. At Christmas, we were at a stage where the majority of our population hadn't received a booster. That has changed over the Christmas period, and now we had uncertainty about the severity of Omicron, and actually a lot of the reduced severity that we're seeing is due to the protection offered through the booster vaccine. So that position is changing. The factors that I would consider in reversing the position that we're in now are when the government moves away from Plan B. I think that's one of the things that I would look to. I'd look to see continued improvement in the vaccination campaign, both first, second and booster doses, and the school campaign too. Hospitalisation rates, we have not seen the full impact of those yet. And community transmission rates. And I would take all of those factors into account before changing the position and advice that I would offer to the council. I think there's a question about people who are immunodeficient. They were previously protected by the government's approach to people who are clinically vulnerable and extremely clinically vulnerable. I'm not aware of any legal position through which I could offer additional protection to people who are immunodeficient at the moment. There was a question about vaccination and do we understand who's not taking up the vaccine and what we're doing about all of that. My colleague Adrian Chapman actually leads on the vaccine hesitancy work. It's my understanding that there is absolutely variation by geography in terms of uptake and ethnicity, with Eastern Europeans being the least likely to take up vaccine. We do have new migrants coming in, and those new migrants are offered vaccination, and we are targeting all of those where either ethnic groups or geographical groups to increase uptake, and have looked at the barriers to uptake, for example, transport or childcare, and have offered solutions to support people to overcome those barriers. We've had the Surge Rapid Response Team, as I've already referred to, who've gone and door knocked. And in the past, we have taken the vaccine bus to workforces where there's lower uptake of the vaccine. And that work will continue. We've had to halt the hyperlocal approach over Christmas and the bus, due to the need to maximise efficiency of our vaccination resource. And we've gone back to the mass vaccination centres. We are moving back to a more localised approach now that there isn't such a pressure on the vaccine resource. and are looking to reinstate the bus by the end of this month. I hope I've covered, I think, yeah, there was a question about what's the council's role in encouraging face coverings. I think we do have a role. We have supported communication campaigns to advise people to wear their face coverings when they're out and about and in crowded spaces. Our environmental health officers also are looking at where this isn't happening. For example, it's been alerted to me that there's an issue with some of our bus companies. We are now working with the police to ensure there's enforcement of face coverings on buses. So that's another thing that we're doing to support mask wearing. I think I've covered most of what was raised. Please do come back to me if I haven't.
I am going to have to draw a line for, we could debate this, I think, all morning, and they're all relevant and important points, but I think I do draw a line to enable us to proceed to the other business. But I just will want to place on record, as ever, our thanks to you, Jyoti, but also to all your team and all the colleagues that are involved in these massive efforts. And I hope that the comments, I'm sure that the comments and the questions put today will also inform your further work, and we thank you for that as well.
Thank you.
We now move on to item 5, the integrated care system, and our position paper as a county council in relation to the ICS. Jyoti will be joining us in presenting that issue as well, but first, Charlotte Black. Sorry, Charlotte, I do apologise, but there is a recommendation to the report, and I should have put that to the meeting. The previous report, we're just noting the update. I'm sure that's uncontroversial, but I formally have to do it. Do people want to note the update? Anyone against? No, that is agreed. I apologise, Charlotte. Back to you.
Thank you, Chair. I'll keep this introduction brief and assume that everyone has had a chance to read the paper. And apologies to those people I've got my back to. It feels very strange, but I'll carry on. The purpose of this paper is to provide a briefing and a sort of orientation really for the committee about the integrated care system being established across Cambridgeshire and Peterborough. The paper is really setting out in particular what the role of the local authority is in this context and the kind of opportunities that we can see, but also some of the challenges that we can see might be ahead. The paper provides a national context and also identifies some specific areas for discussion. So it would be helpful if the committee could sort of note, probably there's two aspects to this. One is understanding the development as a whole, which is a national one, which we're responding to. And the other is really to focus in on the specifics for the county council, which include the principles and priorities in section 5.4 and the criteria that we're proposing should be applied to any opportunities for joint funding, joint posts, etc. I don't plan to go through, because I could probably talk about this for half an hour and explain the various acronyms. I don't plan to actually do that, because I'm sure members will have read the paper. But I think the main thing I would say in terms of summary is the reason this is important is it's a real opportunity to join up health and care at the most local level to improve outcomes. And to move towards more of a sort of place-based approach, building on all the work the council's done on this so far. It's an opportunity to take forward local authority priorities that have already been set, building on the integration we already have in place. And most importantly, I think it's an opportunity to involve the local community in key decisions about health services, and some clear principles have been adopted to support that. It's an opportunity to develop new solutions to some of the common problems, such as workforce, where really we can't tackle them on our own. And so there are really significant opportunities here. And I know the committee will be looking at this again this afternoon. As I say, I won't go through in detail the governance changes, but would ask you to focus on what we've described as what we think are the local opportunities. And I think there are possibly two areas for discussion just to help the chair a little bit. One is just making sure everyone understands exactly what the proposal is. And secondly, to make sure that members of the committee are comfortable with what we're describing as currently are thinking about priorities. I'm going to bring Jyoti in just to talk about the particular opportunity around the Health and Wellbeing Board and the Integrated Care Committee. I get the language mixed up as well with all the different acronyms. So Jyoti will talk about that. But I think the main thing at this stage is just to stress it's early days. This is a sort of position stroke orientation paper, and we will be coming back to the committee with more detail as we start to get into more practical, concrete changes. So perhaps Jyoti would just like to say a bit about the Health and Wellbeing Board.
Please.
Absolutely, thank you, Charlotte. I think we've got a unique opportunity here because of the coterminosity of our health service and our local authorities and the combined authority, and to maximise the benefits that we could have through that coterminosity. We pulled together a development meeting on the 6th of October with all of the key partners, and at that meeting there was agreement that we wanted to work together as a system to draw together all of our resources and energies to push forward on a key few issues to support our population to recover from COVID. At that meeting on the 6th of October, there was agreement to a single health and wellbeing plan for the whole system, and an agreement that we wanted to work together initially on an aligned basis, but working towards integration over time. At that meeting, we agreed to 3 high-level objectives, which were by 2030, we will be the best of our comparators for outcomes for children. We will reduce inequalities in premature mortality by 10%. We will increase the number of years that people spend in good health by 10%. And we agreed to 4 sub-priorities that we will drive forward to achieve those higher level priorities. And they are our children are ready to enter education and exit, prepared for the next phase of their lives, create an environment to give people the opportunities to be as healthy as they can be, reducing poverty through better employment and better housing, and promoting early intervention and prevention measures to improve mental health and well-being. We have a further development day planned for the 17th, so Monday coming, to talk about how we can develop the health and wellbeing strategy further in those 4 priorities further, but also how we can effectively work as a system to deliver the objectives that we have set ourselves. I think there's general excitement about what we can achieve together and to enter this new phase in that collaborative way. And I and colleagues are optimistic about what we can achieve through that approach. Thank you, Chair.
Any summing up, Charlotte, or are you happy with that? No, that's fine. Well, thank you to Charlotte. Thank you to Jyoti. I'll say in introduction only this. I regard this as potentially the most important paper that we've dealt with since this administration came to power in May last year. It's a huge reorganisation of the health service, but it also has direct implications for us as a local authority and the way we deliver our services. And the officers, with my thanks to them, have worked intensively together and with us to produce this report, which is an orientation and strategy report. It's not a decision, but it will guide the authorities' contribution to the ICS in the period going ahead, because that's such an important part of how services will be delivered to people in Cambridgeshire. As I say, I regard this as very, very important indeed. We now move to the debate, and the first person I have is Councillor Daunton.
Thank you, Chairman. Thank you very much, Director of Public Health and Charlotte, for your comments. I've got a general question and then 2 specific points. My general question is about governance and tradition and an operational mode. So we're bringing together here different groups with different traditions, different governance, different ways of working, different approaches to work. How will those differences be brought together and managed and brought together in a shared endeavour? How is that being talked about, discussed and worked towards? Then a very specific point, and I think it's 5 point in the paper, 5.5.1. I would just like a bit of unpacking of this sentence. Use community development approaches that empower people and communities making connections to social action. Perhaps you could explain what you mean by that. It's not evident to me. And then my third point is on think communities. It's actually in the next paragraph, 5.5.2. I would hope that we might be able to focus the think communities work on health and well-being, give it a genuine focus and use it effectively in that particular area. Those are my 3 points at the moment, Chairman. Thank you.
Thank you very much. Councillor Wilson, please.
Thank you, Chair. I've got 2 points. The first one is in 5.7.1, where we're asked to agree the criteria. That one of them is about congruence with county council priorities. And I would like to broaden that out and be clear what priorities we're talking about here, because clearly it's not anything to do with potholes or repairing roads and the like. And ensure that somewhere it specifically talks about improving efficiency and effectiveness, and include something about developing and retaining and recruiting appropriate staff. So that's one point. The second is about the appointment of preferred providers, and it's not clear to me precisely how these are going to be identified. It makes eminent sense to go to CPFT for their mental health expertise, but what about some of the other services which are provided and will be needed in the future by the ICS? And related to that is, can we have an assurance that the NHS will be the first choice provider and the private sector will only be asked to step in if the NHS cannot meet the expectations? Thank you.
Thank you. Councillor Boulat, please.
Thank you, Chair. And again, thank you to everyone involved for what is a huge amount of work on this paper, especially considering the timing for central government to do major changes whilst the NHS is still dealing with the pandemic, but probably we just have to make the best out of it, I guess. So I welcome some of the positive points of this paper, including the issues around collaboration with other committees, within communities, and co-production in many of the areas. Now, we all know that a lot of patients want this integration, but equally patients want, and our residents expect, democratic accountability. And Councillor Danton already raised some of those critical points. I wanted to raise one specific point, which is in 4.6 in the paper. There's a reference there from the King's Fund, some of the concerns there, and I quote, pointing the sweeping powers of the Secretary of State to intervene in local decisions within the legislation. So it's a really simple question here, how can we have proper democratic accountability, especially at the local level, when we're subject to those powers? And if we could have some detail, perhaps, if we know yet what those powers are and in which cases they can be applied, what that actually means. So a bit of unpacking on that 4.6 point, because it seems to me it's really important to the conversations around accountability and local level intervention, as well as the members' voices and accountability on the health issues as well. And on a similar note, I think there have been a lot of concerns, especially in the national level debates around top-down organization of health. So many key stakeholders are looking at the British Medical Association, some trade unions, health campaigners, various campaigns about keeping the NHS public, and as well Labour and Liberal Democrat MPs in Parliament. There are a lot of concerns expressed about how some of those reforms could potentially open the door to increase privatizing of services. So I was wondering, what is our response as a council to those concerns? Thank you.
Thank you. Councillor Bowden.
Thank you, Chair. This is, in the last 20 odd years, the 4th major reorganisation of the NHS. And sometimes it feels as though we spend more time planning, implementing, and then bedding in reforms to the system than we do actually running the system. Sometimes it feels like that. There are parts of these reforms which I very much welcome indeed, especially the attempts which are being made, and I'll use the word attempts deliberately, to improve the linkage between social care and medical care. I don't think it's a perfect set of reforms by a long way, but ultimately we are in this environment which has been set by government, and we will have to make the best of it. And so it's not really very productive to go into criticism of any of the individual parts of it, other than to say, and I do concur with the last speaker, that I'm far from convinced that we're going to get greater public accountability within the whole system from the new arrangements compared with the ones which we've inherited. But we'll have to work within the limitations of what is provided to us. And within that, in the recommendations and what we're being asked to comment on today, we're being asked whether we agree with the priorities and principles which are listed in the report in paragraph 5.4. And I went to those, and I was initially extremely disappointed when I read the 14 priorities and principles which were listed. And then I realized those priorities and principles, or at least I'm assuming I'm correct in saying this, I realized those priorities and principles haven't been put in any order particularly. They're just listed there as priorities and principles. And what I would ask the administration to consider doing, I'm not asking for a change now, I'm asking for this to be considered for the way in which this is presented in the future and dealt with in the future, is that at least the most important and the most fundamental priorities and principles are themselves prioritized within this list of 14, because we've got 14 bullet points there, and I had to get down to bullet point 5 and bullet point 6 before I saw what I thought should be the fundamental priorities which we have. I'm not saying the other 12 are unimportant, far from it, but I'm saying that all of those other 12 should be subject to these first two, that number 5 and number 6. And that is number 6, most importantly, measurably improving health and well-being outcomes and reducing health inequalities for the population. That surely must be the fundamental thing this is all about. And second to that, and very closely associated with it, is bullet point 5, shifting resource towards prevention, community-based solutions, and the moving of resources from acute to community, ensuring that resources are spent efficiently to deliver the best outcome per pound spent. And I think that those two priorities of the 14 really are absolutely fundamental to what we would want to get out of this whole change and the future of our health and social care systems. So my request to you, Chair, is for consideration to be given for the future that those two priorities out of the 14 are themselves emphasised and prioritised as being fundamental to what it is we're trying to do. It just helps sometimes, if you're talking about priorities, to prioritise your priorities. Thank you, Chair.
Thank you, that's been heard. I will comment in my summing up, but just to say that's been heard. I next have Councillor van der Len.
Whoops, very tricky. Thank you, Chair. Yeah, just to say thank you very, very much to our officers and to Richard. We've been working intensively to prepare this paper. And to reflect on the comments of the chair and Councillor Bowden and the big picture, this is part of enormous health reforms, and it demands our attention whether we like it or not. And of course, the next paper on our agenda today, Market Pressures, is actually about the phenomenal impact that these reforms will have on us as a local authority. So yeah, there's much to be excited about, much to be daunted about. I wanted to just say that in terms of collaboration, as opposed to cooperation, which is a really important theme of these reforms, I think that that actually buys right into the instincts that we're seeing around the system here. And I've been really struck by the consensus, real consensus that this is what we want to do, what we need to do. And some of that it's almost like riding a wave in some instances. What I've learned about the Children's Collaborative shows that this is something that has organically evolved over the past few years and has now actually got a name put on it called Children's Collaborative. The work in this council during the pandemic, led by Adrian Chapman around the COVID, the central hub, and the coordination of all of these incredible community groups all around the county demonstrate, again, these principles and themes, and there's an urgency to build upon those now. And maybe hidden away, tucked away, so important is the work of public health in the community. And I would point out, for example, park runs, which everyone gets excited about. You know, when's the next park run? Well, this is actually public health activity. We don't have to label it that, but that is the kind of work that is just vital if we're talking about children and you know, living well and preventing getting sick in the first place. So those are things that we're doing already, and we can build more strongly. The document has many references to decentralization. Without going into a lot of detail, but there's an implication about what it means. And it means, you know, we're talking about health and social care and living well in our daily lives. In our daily lives means where we live, with our neighbors, in our communities. It's a very local concept. And I think this is where we as a local authority can really contribute to the overall conversation for the benefit of the NHS partners who are going to be more remote and more clinically based. So I think we have a lot of work to do in this council on what we mean by decentralization and how we can allow that to go forward in a really helpful and supportive way for this project. And remembering that this council spends by far the most of its budget on social care, and we have a huge responsibility there. Then just to do a couple of small points, whether not small points, I think for us at community level, we will have a lot of work to do on understanding the role of GP services. And I know that our Think Communities team does currently offer some support in principle to our primary care networks. And that is something that needs to be built upon. Everyone's so frantically dealing with COVID that sometimes, you know, there's an offer of support that we're too busy to take up. So that's an area that'd be really interesting for us to explore. Similarly, community pharmacies, I think, are kind of a hidden gem, and we know how important they've been during COVID. And I think that voice of community pharmacies, I believe, will come into play within the Health and Wellbeing Board context. And then finally, just a possible typo. We have talked about acronyms and terms and so on, and apologies because I've missed this in pre-reading the paper, but under the priorities and principles, just more than halfway down, there's a reference to care at home. Is that care together? So there we go. And probably it's just important to finish by saying, isn't it incredible that everyone is doing this in the middle of a pandemic? We don't have any choice. It has to be done. And there's a lot of learning we're taking from the pandemic. Thanks.
Thank you very much. And I just indicate Councillor van der Ven, as chair of our Health and Wellbeing Board, will be playing a major role in delivering on this. And we thank her for all her efforts in relation to the preparations to really get the Health and Wellbeing Board back up and running, but also this close relationship. There will be an integrated care partnership, and wish you well, and we'll be supporting you in those efforts. Councillor Slatter, please.
Thank you, and I echo what you say about our vice chair. I think many of the things you said, and my heart sings. As many of you know, I worked as a sort of one-woman integrated service for many years as a city councillor and a community nurse and a member of the St John Ambulance, particularly focusing on homeless people and their feet. Now, that does give me some insight. I don't want to go from the particular to the general. It doesn't always apply, but it does give me insight, I think. One comment on 3.3. When I saw acting sooner to help those with preventable conditions, I found that slightly strange wording. We all have preventable conditions.
when the conditions are prevented, you never know about it, of course, and that is essentially prevention. So I was glad to see in 5.4, we do get the word prevention, because I know that Jyoti and I share this real concern for prevention. It's a bit of a nursey thing for me, but it's also it goes with all sorts of things like parenting and being a counsellor. But what I was concerned about is if we have numbered them, and thank you, Councillor Bowden, number 5, which includes prevention, to my mind, this is priorities and principles in 5.4, where we've got number 5 is shifting resource towards prevention, community-based solutions, and moving to deliver, blah, blah, blah. That's far too much in one thing. I really would like to see prevention out there and strong, especially as a lot of it is in our hands. And I am so pleased that at last we may be getting more cooperation and the balance of power, as in the previous paragraph, 5.3 is key. We really do need to make sure that the money that goes to acute and primary, which is now going together to acute and prime, they're not hopefully fighting over it as they have in the past. We actually share it equally. And I know that Councillor Van der Ven will be doing her best to make sure that there is a proper appreciation of the services that help with ill health prevention. That is really key. When it comes to the ways in which it's going to be done, the devil is going to be in the detail. I was a little bit alarmed to see in 3.8 the CQC apparently having tremendous power. Now, they have their protocols, and sometimes the ways in which one is meant to jump through particular hoops can prevent one delivering a service. I would echo Councillor Daunton, I think it was, who was talking about different cultures. An example of this, just to illustrate it and clarify what may be otherwise a muddled argument. If you're trying to deliver foot care to the homeless, you cannot do it within the NHS protocols. And when you even do it in winter comfort and you are inspected by the CQC, you have to spend a lot of your time explaining yourself to them, because they come in with all sorts of suppositions about dogs, for example, that just cannot be carried out, or people being seen on their own, which again cannot be done. So that is my concern, is when we are trying to put people together, we do need to have people listening to one another and some compromises in culture, and some what might be seen by some as lowering of standards in order to deliver the services. The care together might well be the way that can be done, I think, because having a pedicure rather than having your nails cut quickly might well be the sort of way we can do it. And the protocols do have to be considered carefully, in my opinion. Thank you. There's more I could say, but that's because it obsesses me and I'd be able to stop.
No, thank you indeed very much. Last speaker is Councillor Murphy.
Thank you very much. And thank you very much for the paper and the enormous amount of work that's gone into getting the thinking to this stage. It's quite clear that it's hard to overstate just how daunting a prospect it is, to what a challenge this is to make this reorganisation happen. And there's an understandable, therefore, focus in the paper on, if you like, the mechanics. And I completely understand that. In fact, it's obviously very necessary and it's very well done. But I hope, in a spirit of sort of constructive, playing a role where we can actually step back a little bit and say, how can we improve this, or is there anything else in our thinking? The thought occurs to me that if we look at 5.4, the priorities and principles, the thing that struck me as someone who has not been involved in the detail of constructing this incredibly challenging set of initiatives, it struck me that a lot of these points are really from the service deliverer's point of view. And it might be helpful to, and I don't disagree with any of them, but it might be helpful, a bit like Councillor Daunton was talking about, what does a community development approach, mean? It might be helpful to think about adding or clarifying to make it some points there from an individual or patient or resident's point of view. What are the sort of benefits they're going to see from what changes they're going to see? Will services be more responsive to them as individuals? Will they see more joined up or efficient care? Will they have better informed care because the records are in play, information is shared? Will they have a better sense of ownership and control because of the democratic input? I mean, there's evidence from Denmark, for example, that that's a really important feature. It's not so much that they're wrong. I'm not disagreeing with that, but in a sense, if we have some points there which are from what the residents are expecting to see, what individuals are expecting to see, that also helps our mindset of thinking, what are the positives that we can deliver out of this for people? Because the question will be, well, what difference will it make? And it will just help to highlight that without a vast amount of extra work.
Thank you. A few points from myself. Firstly, I think it was essential that we as a council developed a position paper so that we had a strategy for this and didn't just fall into it. And I think there was a danger of that under the old administration. I hope that we've put that right. It is important to put on record that there are already joint arrangements, for example, in the field of learning difficulties or community equipment, and we can learn from that. But there were previously joint arrangements in the field of older people, and we had to withdraw, the council at the time had to withdraw from them, and there were lessons to learn from that. And so reflecting on that and recognising that there are pros and cons, that we want this to work, but we want to go into it with a balanced view and with our eyes open, is the right position for us as a council, for a council to take. I share the views expressed by members about issues about local democratic accountability. There's very tight top-down accountability within the health service to the Department of Health and NHS England. But they say, and politicians at government levels say, they want local flexibility. And so we have to see whether those words are right and whether we can make it happen. And so we have a really crucial role in ensuring that local democratic accountability element in the process. And I know, by the way, our health partners who will meet this afternoon and their colleagues agree with that and want that pressure and think that will be helpful to making the whole efforts successful. Councillor van der Ven and myself have been very informed by the Local Government Association position in trying to input to this paper. We've been in part of 2 events with the LGA and received advice from their advisors that has gone to officers, but also to ourselves. And councils up and down the country are struggling with this. It's challenging, it's new, it's different, it's complex. It does have some downsides as well as some upsides, and we need to be honest about that. And the fact that we honestly as a council today are openly debating that and putting it on the record in terms of our position paper, I hope will not simply be the right thing to do, but will increase public confidence that we're there minding the public interest, the local public interest in our proper democratic role as councillors in relation to all of this. I heard what was said about 5.4 and the different priorities. We will reflect on that. But what I will say, talking to our health partners, is in the outgoing CCG for incoming ICS, is that they've received guidance document after guidance document of hundreds of pages each time at a month or 2 months apart from government about how they have to do this. So for us to have 14 objectives in a third of a page or a half of a page of A4, I think our officers are more than capable of looking at the multiple priorities. But I think that I don't want to reject what was said on that. I simply want to put it into that context. I think it's hugely beneficial that we lay down criteria so that we don't fall into any arrangements. I'm sure that wouldn't have happened anyway, but we're not simply saying that these decisions will be taken back to committee. We're laying down some criteria by which we will then take the decisions, and we would ask our officers to reflect on that. I think that's wholly beneficial, and it hasn't been referred to yet, but our role as a scrutiny function changes, because the ICS will be a partner, will be a part of delivering, not just sitting on the outside watching and asking questions. And so this idea that we build within Jyoti's team more capacity to analyse and to advise on health strategy, I think is an important development, which is part of this and part of the recommendations. We already have that capacity, and Kate Parker, for example, plays a really important role, but to build on that in the future is certainly part of what we're agreeing today. It is important. I think the local public will know that in Parliament, this has been hugely controversial, and there have been many arguments against this on all sides of the chamber, by the way, as there have been today within the committee. And so for us to go into it without reflecting on that and showing that we've got our eyes open would have been a mistake. And I think it strengthens our position to be able to show our awareness to that, and that we are properly cognizant of the risks as well as the advantages going on. One of those has been referred to by Councillor Bula in relation to privatisation. The government has denied that. You know, the test will be the ratio of NHS in-house services versus the amount of private provision, and if it grows up or creeps up over time. And I think Councillor Wilson's reference to the idea of the NHS being the first choice provider is enormously helpful. I hope you'll say that as well to the Chief Executive and to the Chair this afternoon. And I think those, including Councillor Bowden, who have talked about this key point of acute delivery of services within the health service versus prevention, we all believe that, and our Director of Public Health and her team are delivering that day in, day out. The test is whether the whole system supports that, and it's not just our public health team beavering away in Cambridgeshire County Council, but it's the system that is, and it's about decisions, about resources, which is why the governance and the board of the ICS is so important. We've got one voting member on that board, so we can say it all we like, but we're never going to win the vote just as ourselves. So we have to find ways within the governments to get the governance supporting those objectives as a whole system, which is where I believe the Health and Wellbeing Board and acting de facto as a merged Health and Wellbeing Board and Integrated Care Partnership is so important, and our role as the chair of it is so important to this. And I think we've made some genuine progress with our health partners in order to achieve that, and I'm very pleased, and I thank them for that. And I align myself with everyone who has said, including Charlotte in your presentation, about how important this is in realising our ambition for Care Together, to build services around local people and local communities and build up rather than top down how we wanted to deliver the service. And it is a great aspiration. Many in the social work world are adopting that, but delivering it is damn harder than it is actually saying you want to do it. And this is our chance to do it. And it is absolutely essential, and when we do that we don't get the ICS doing it down one track and us as an authority in decentralisation doing it down some other duplicating track. We should be pulling together on that and making sure synergy between the two. And we've consulted Councillor Sanderson and our friends in the Communities and Social Inclusion Committee, Social Mobility and Inclusion Committee on that, and they have an important role to play in relation to that. You know, I do want to place on record that I think Councillor van der Ven and myself have met the ICS interim chair and now chair and chief executive probably every 2 to 3 weeks during the time we've been in our position in different meetings. We've got an excellent relationship with them. And that does reflect the relationship that exists between our officers and the health partners at every level. There are very difficult issues to manage within that on both sides, in truth, but the relationships are good. And I think you'll see that this afternoon. But what we hope is that this paper will empower our officers by giving them the set of values and principles and criteria through which we want them to engage in all of these processes, and through engaging to make them a success. And I believe it's been the care that's gone into developing this strategy, and the thought and exchanges have been very worthwhile. And I'm very proud actually of the paper that has been put before committee today. And once again, thank Charlotte and all her colleagues for their role in working with us to achieve it. Charlotte.
Thank you very much, Chair. And I think the questions that the committee has raised are really important ones. And I suppose one thing I would say as a starter is that I think it would be worth thinking about how you'd like to feed those into the scrutiny session this afternoon, but I'll certainly answer them where I can. So, Councillor Daunton, you asked a question about how will, in a sense, different traditions of forms of governance be brought together. I think that's sort of what we're seeing now happening in action. I think it's really positive that myself and Jyoti in our respective roles will have places on the ICB. Between us, we will have one voting place, which is something that we haven't had before. I think the discussions happening around the Health and Wellbeing Board and the ICPC are an indication of the fact that we're actually trying to create something quite new here. I think that the local authority's got a lot to bring to the table, actually, and I think that the key thing we have got to bring to the table is, as the Chair was just saying, is that real focus on place and neighbourhood and what matters to local people. And I think the challenge from members today about language and how we present our priorities exemplifies that, actually. So really, really useful. And I do think that's recognised by NHS partners. The question about 551 and the principles about how the ICS will work with people and communities, these are national principles that I think have been adopted locally, but a really good example of the one, Councillor Daunton, that you've raised, I think, is the way in which the community has worked with the sort of health and care system in the pandemic, and the way that community solutions have been developed and built upon. So that's just one example. Or did you want to come back?
We do have time difficulties. I think it's such an important debate, but I'm going to ask Charlotte to continue with apology.
And I also agree, Councillor Daunton, that I think this is an opportunity for a very practical focus for the Think Communities approach. Councillor Wilson asked questions about the appointment of preferred providers and how will this happen. So there is a very clear process which health NHS providers will have to go through. It will be very rigorous. We've been told it could take up to 18 months, but I think the way in which it will work is that, for example, Cambridgeshire Community Services is the main provider of children's services. So they will put themselves forward as the preferred provider for children's services, for example. But I think there's an awful lot of work still to be done on this, and I think it might be an area to explore in the meeting this afternoon. There's been a couple of questions about moving a sort of seeking reassurance really around not going down the sort of privatisation route. Once again, I think worth picking up this afternoon, but I think if you read the documentation and the response to the consultation to the Constitution, I think there are some very encouraging messages about that. Councillor Bulak, you asked a question about Secretary of State powers of intervention, and what does that mean? That sort of exists now. So if there is a system failure or a sense that either a local authority or an NHS trust is not fulfilling their responsibilities and is in essence failing individually or as a system, there are Secretary of State powers of intervention. That comes in many different forms, but it sort of links to the question that was raised around CQC. So certainly from a local authority perspective, either CQC or Ofsted will be the main organisations that will be, in a sense, assessing and judging local authority performance. So that's the sort of area that we need to focus on. But I do agree with the observations about the constraints of the CQC inspection framework that were made by Councillor Slatter. completely take on board the comments about prioritisation. I think at this stage we wanted to put everything in there, but recognise that might need some rationalisation and reordering, which was part of what I wanted to do, was to bring it to you in its current form really as a committee so that you could help us shape it. And I think there have also been some comments about prioritisation, the need to make prevention more explicit. I think that's also a very fair comment, and we can certainly take those comments away. And we can also take away the comment from Councillor Murphy about finding a way of explaining all of this in a way that makes sense to residents and patients, and they're not always the same thing. And I think ultimately you're absolutely right. I think what people really want to know is what difference will this make to me? And so I think it is something that we regularly feed into the discussions with the health partners about making sense of this to local people, because they're not that interested in governance. They're very interested in getting help when they need it, and in health and well-being in its broadest sense.
I am minded by the timetable, but I'm also minded that the Director of Public Health has an important, crucial role within this. Jyoti, I will also ask you, please, to comment, make any additional comments on what you've heard.
I think a couple of comments from me. Before arriving here, I worked in Wales, and they have an integrated system there, and have done for some time for the health service, that is, not so much for social care. And I think what I would say is that putting it on paper doesn't make it so, in my experience. And I think we will have to work hard to actually engender that shift towards primary and community services and towards prevention. I think there was a comment about shared endeavours. I think the work that we've done so far has really gained agreement from the system that they do want to work together towards these shared priorities. Again, I think saying it doesn't necessarily make it so, and we've got to work with the system to make sure that they do deliver against what they have committed to deliver against, and that we challenge each other to make sure that we've got a lot to recover post-COVID. You know, things have gotten worse, obesity has gotten worse, alcohol consumption has gotten worse, and we haven't really been able to put the effort and attention into those issues that we should have done. And I think we've got to challenge ourselves that we are going to make that scale shift, or that system shift, to really turn back the dial on things that have gotten worse, but to take it back even further and reduce inequalities and improve health outcomes. So a lot more challenge, I think, is needed to make sure we deliver against what we've all committed to.
Thank you so much to both yourself and to Charlotte. The recommendations are in the report. Can I not read them out, Tamar, or do I have to read them out? Do I have to read? Right, I'm just aware people are watching online. I think I'd better summarise them. I'm sorry, because of the people watching online. Thank you, Councillor van der Ven. So we're noting the national and local context, the development of the ICS. We're supporting the principles and priorities set out in section 5.4 of the report. We note that the Health and Wellbeing Board and the Integrated Care Partnership will be aligned and operate as a committee in common with aligned membership of both. We confirm the criteria in section 5.7.1 that will be applied to any county council decisions about ICS integrated services, joint appointments or joint commissioning arrangements. We confirm that the council will consider expanding its health policy capacity to provide advice to members' offices in their work with the ICS, and we will champion the principle of local democratic accountability in the ICS in accordance with section 5.8 of the report. Is there anybody who wants to differ on that? If you just indicate. Can I take it in the report? No, I think it's a decision report. I am going to ask for a show of hands. Those in favour of the report, please show. It is indeed, I think, yes, it is unanimous. And so I thank members on all sides of the committee, opposition and joint administration members. I think it's been an excellent debate to a really important report, and I thank you. I've deliberately allowed full debate of that. I'm in the committee's hands with how we deal with the rest of the business. We've got 3 really important urgent items. My own view as chair is that they're pretty obviously urgent and we need to get on and do them. But as chair, I also will never stop democratic scrutiny and questioning of any decisions that are made. But if members are minded to agree with what I've said, can we deal with them in a very concise way? The health partners will come at 1 o'clock. So the danger is we lose our lunch hour if we don't do that. I'm going to ask officers to present both reports with 2 minutes maximum, if that's okay. Of course, that won't stop them answering any questions with the length that is desired and needed for the question to be asked. So that no question will be left unanswered, I promise you. But it may well be, if members are minded to have a similar view that I have, that we can get through these really quite quickly. So I hope that that's laid down that as fairly. And I just repeat, I will never quash proper concern or disagreement if that does exist on any item. We move to adult market pressures. Item 6, online will pattern is about to appear on the screen on my right, and happily you do. Good morning to you, Will, and off you go.
Good morning, thank you. Good morning, everyone. And I'll try not to take too much of the next presenter's time in this. I will take the paper as read, if that's okay, and I will briefly introduce it. So the paper's asking the committee to support the approach and recommendations being made to support our providers, and more specifically the pressures that they're experiencing. It's also asking for agreement to the proposed distribution of the Workforce Development Fund. So our providers are under significant and sustained financial pressures, and they're not just workforce related. They are a whole raft of inflationary pressures and increases, and we've tried to give some examples of those in section 1.2. We've been actively engaging with our providers around these pressures, and we've done that for all sorts of reasons. Not least is the need to ensure that we maintain capacity that we need going forward, particularly mid-term capacity. We've started to see a trend of providers wanting to, and in some cases have, handed back packages of care as a result of these financial pressures. And this paper is in part focusing about mitigating those handbacks from increasing. We've considered a number of options and we've detailed them in the paper. We've detailed the options to achieve more long-term or mid-term capacity and sustainability, and we're recommending option 4. That is to say, the recommendation we believe that we should be taking is a targeted approach to this. That comes with a financial implication, and which is a £2.2 million investment in year, which we're proposing we cover through largely through the underspend around on our adult social care budgets. But it does also introduce a £2 million additional investment into next year.
Can we leave it there, Will? Is that okay?
Sorry, Richard, if I just just bring to the attention, if I may, the deployment of the Workforce Recruitment and Retention Fund, which is listed in 2.19, where we're looking for agreement to passport 80% of the fund through to our providers, but keep 20% of the fund to address our own workforce issues, specifically the retention of key frontline social care roles and staff, and that more detail will be presented in the next paper.
Perfect. Thank you very much. Which members I see? Councillor Wilson, Councillor Bula, anyone else? Councillor Wilson, Councillor Bula. Okay, those two contributions. Councillor Wilson first, please.
Thanks, Chair, and thanks, Will. Two questions. One slightly tongue-in-cheek. if these people are saying they wish to hand back contracts, can we not say, well, you signed up to a contract and that's just tough? If they happen to have been in a good position where they were making loads of money, I don't suppose we'd be in a position where we could go back to them and say, you're making loads of money, so we'll have a bit back. And the second item is relating to the comment about loss of income due to private occupancy levels have fallen by 28%. I just wondered if you could give us a bit more explanation about that, please. Thank you.
Thank you. It is important to have balance in the debates, and I've seen Councillor Howell from the opposition side. I'll take him next.
Oh, thank you, Chairman. Chairman, very quickly, with regards to the last point that was brought up on 2.19.2, and it says there, the first bullet point, 80% of funding be passported to market to address workforce pressures. Can we please just make sure and do an audit that it is actually passed to those lined, the frontline workers, that they have actually been supported there, and that doesn't go into some sort of fund for the agency to dip into when they see fit, but it's actually the people who are doing the actual work is actually benefiting from this. Thank you.
Thank you. And Councillor Boulat, please.
Thank you, Chair. I'll try to be brief. Just a couple of questions. I note in 1.2, it's very useful to have this context. I note that the impact of Brexit and care staff leaving the UK. So I was wondering if you have any figures on what percentage of our staff comes from abroad, and what is the, if any, comparative points compared to the last 5 or 6 years or so. As you know, in December 2021, the government, I think, finally woke up to the economic pressures and added care staff in the shortage occupation lists for the new immigration system. So I was wondering, what difference does this make, or do we expect this to make any difference in the staff shortages, particularly considering that we're speaking about short-term, well, 12 months visas, and also an annual salary minimum of 28,480, which we know excludes some roles. So in that light, I welcome the living wage points and increases in pay as well. So any kind of comments on this? Do we expect it to make any difference, especially medium and long term? Thank you.
Justine Hartley has also been listening, and I didn't invite her at the beginning, so I'm going to invite her to do the first answers and then Will to pick up anything else. Justine.
Actually, Richard,
okay.
Shall I answer those?
There was I trying to be really equal and democratic. Well, now I'm going to ask Justine first, because we didn't hear from her earlier, and it gives her a chance to answer the questions, and then maybe nothing left for you, Will, at the end. Who knows?
I think there might be. So Councillor Wilson's, I think, first question was, can we not say it's tough and hand it back? I think the reality is that some of these providers might go under as a result of that, and obviously that has care impacts for the people that we're looking after. So it would be lovely if it was that simple, but I suspect that will say from a commissioning perspective it most certainly isn't. I'm not quite sure I understand the loss of income due to private occupancy question. So maybe, Will, you can pick that one up. In terms of Councillor Howell's question about frontline workers, so part of this paper is about the workforce retention grant being given to providers, and absolutely that has to be spent on frontline work staff. We cannot have it going to the bottom line of care homes. So part of our grant agreement with those care homes will be very much about it has to go to frontline workers, otherwise we won't be paying it, because that wouldn't then be in terms of the conditions of the grant, and obviously that applies to our bits as well. You know, a lot of what we're doing and a lot of what we're doing in the business plan in terms of real living wage and everything else is about getting that money to frontline workers. So that is part of our focus. Staff from abroad, Will, I don't know if you can answer that one as well. I suspect that it's difficult for us to know actually what percentage of our staff from abroad, given that these are not our staff, they are care home provider staff, and what impact that has. But I'll leave that one to Will to pick up if he is able to provide an answer.
Will, please. Thank you, Justine.
Thank you, Justine. Thank you, Chair. So I'll address the loss of income from the self-funder occupancy, and that actually is a direct result of the COVID and a change in some of the discharge processes. So as you know, when we discharge people from hospital, that first 6 weeks is funded, and obviously providers are seeing an impact as a result of that, in terms of, because we don't delineate during that 6 week whether that's a self-funder or not. As far as the workforce is concerned, the feedback when we talk to the care associations and our providers, particularly around bringing care workers into the UK, the feedback is that it has thus far had very limited positive impact, and is actually very expensive in terms of, you know, recruiting and training and certificating people into the UK. So far, the feedback is that it's very limited, and of course, the workforce is, you know, an attractive workforce and resource that, you know, and we've heard about other industries attracting that resource away from the care market, and that is something that we're working with providers to try and mitigate against. As far as the handbacks of the contracts typically are on a 28-day basis, and as Justin quite rightly says, we do push back, and it is a negotiation, if you like, but, you know, at the end of the day, if the provider is unable to meet the needs of an individual, then it is actually, at the end of the day, our responsibility.
Thank you. And just to alert members of the committee, Will himself is returning from a period of ill health, so it's really good that you're with us today, and thank you for your contributions. The recommendations in the report are to agree to the implementation of the proposed approach to managing the market pressures with the budget implications for 22-23 and beyond built into the business plan, and agree to the proposed use of the Workforce Development Grant round 2. Any disagreement on that people want to indicate? Can I announce that it's been agreed by consensus? Yep, I'm saying nods all around the table. Thank you very much. And thank you to Will and Justine. We now move to next item, so I'm having to run over the allocation. No, I've run to the urgent item. I do apologise. It's item 7, the adult social care retention payments. Charlotte, please.
Thank you very much, Chair. I'll keep this very brief. So we have a challenge, as the committee is aware, in terms of recruitment and retention of our adult social workers. We've identified a number of teams within Cambridgeshire, who are particularly the frontline teams who do the sort of face-to-face Care Act assessments, reviews, and plan people's care packages and work out the best solution to people's care needs. So we don't think this applies to all teams, but as we've included in the paper, we have certain teams where actually we do have a problem with retention. We've looked at the data, and we can see from the data that we're not retaining people as long as we would wish, and we think some of this. There are several possible reasons for this, but we've looked at good practice elsewhere and seen that within children's services there has been a retention scheme in place which has been successful. So the proposal here is that we adopt that scheme for adult social workers. As I say, any of those teams where we have a problem, and if we got to the point where we didn't have a problem, we would review the arrangement. The paper sets out which teams that would apply to and how it would work. And my strong view really is that unless we do take steps like this, I think we will find ourselves struggling to meet our statutory functions. And we are going to have, those are going to change as a result of the adult social care reform. So we have also included in the paper details that, for example, the number of people who may actually now require or will require an assessment as they get closer to the new care cap is going to increase. So we're going to basically need more social workers to do that. There are lots of different options, but we've looked at them and the conclusion we've reached across county council officers, including with finance colleagues and HR colleagues, is this is the best solution at the moment. So really seeking your agreement to the first year costs will be if you approve, be covered within the workforce grant, and really wanting to build into business planning the subsequent 2 years. Thank you.
Thanks once again. Justine is listening, and I'll invite her to come in response to any questions. Are there any questions from members? Councillor Slato, please.
Thank you. At the last meeting of this committee, we were asked to make an urgent response to the fact that we could take advantage of an agency employment scheme. I've not spoken to it as accurately as I could. Hopefully that what we're talking about today will make that increasingly unnecessary. Perhaps the officer could just put it in that context for me. As I say, we know that agencies are useful and we know why people work for them. But if we can make our own employment more attractive, obviously that's what we want to do. And is that part of this? And will we see the benefit in needing less agency? Thank you.
Councillor Boulat, please.
Thank you, Chair. A very specific question on 2.3. I was wondering if there's any insight on why the vacancies, especially on learning disability and adults with autism, are quite significantly higher than the other categories and have been increasing quite significantly over time. I kind of noted that as a bit of an outlier, and I was wondering if there's any kind of context to that. And a broader question about the retention payments. So they have been effective in other areas, but I'm wondering in the longer term future, are they likely to increase budget pressures over time, or are there enough as they are now? Because I would imagine that other authorities will also think about similar models. And if the national staff shortage is not really sorted out in a sustainable way, discussion years to come whether the increased competition from other local authorities will actually put even more pressure on finances. So any kind of comment on that? Thank you.
Thank you. Councillor Wilson, please.
Thanks, Jim. My comment is very similar to Councillor Boulat's. I struggled to understand the table on page 73, and particularly the business planning bid, which I think is probably the key line for us about what this is likely to cost over the next few years. So is it saying that in 2022, we're not going to do anything because we're nearly at the end of the financial year? 22-23, we're going to need to add 302,000 to the budget, and then 100 a further, or reducing 152 in the next year. And then the second question is, are other neighbouring counties doing exactly the same so that we are acting in step with them? Thank you.
Last speaker, Councillor van der Ven.
Thanks. I just wanted to underscore the point made under the main issues in terms of the change in the cap on payment and the enormous additional responsibility that this council faces, and that we need to not only protect and nurture now, but we need to build out. And I think that's an undercurrent here in this paper that we should be very, very mindful and somewhat concerned about. Thanks.
And a couple of words from me. Firstly, we all know what stress our health service colleagues are under, but we don't talk enough about the stress our own staff are under. They're all dealing with very complex and difficult situation. And it is right that we acknowledge the work that they're doing and see the value in keeping them doing that work. I also want to say that there is a danger. There's an auction, 2 members referred to it, with other authorities, and we're just all bidding up and bidding up. It doesn't actually succeed in retaining staff. What I've said to officers is we need to get ahead of the curve on that, and I think them bringing this to us is a sign of a response to that, for which I thank them. I'll close by saying Cambridgeshire is a really great place to be a social worker. Let's be honest, we all live here and we enjoy it and we know the quality of life, but it's a damn expensive place in some places to live and to work. And this is a recognition that people who are committed to us, committed to the services, committed to the people who need the services, need to be properly recompensed, given the cost of living that exists within Cambridgeshire. And this is our attempt to do that. And I think it's utterly right. I'll take Justine first again, please.
Okay, thank you. I'm going to start with Councillor Wilson's question in the table on page 73. So just to explain this, so it goes across a number of groups, and you can see the top line of the 128,000 in this year. So what we're saying with that is the workforce retention grant that we've just talked about in the previous paper is very clear that we can use that to award our own internal social workers and pay retention payments to them. So that workforce grant would be used to fund the first year, and that's why there's no funding request for that. Then it would be 302,000 built into the business plan. The way the business plan works is it's on a sort of cumulative basis. So you put 302,000 of budget in, and that stays in there unless you take it back out again. So it's 302 in 2022-23, and then a further 152 in 23-24. There's a couple of other lines in that table about learning disabilities and children's disabilities. In both those areas, we have what are called vacancy savings targets. So we always have sort of turnover, and they can pay for that within their vacancy savings targets. They don't need any additional money. So that's why those ones are taken out. But within adults and safeguarding, and this sort of picks up as well on Councillor Slatter's point, we don't have the capacity within our vacancy savings, and part of that is because we are paying a lot to agency staff, and they are obviously more expensive than substantive posts. So in terms of will this help in terms of agency staff, we very much hope so. We very much hope that this will turn around the numbers so that we are retaining people better, and we don't need to use agency so much. Just moving on to Councillor Boulat's paper, why are there vacancies in LD? I think we're in a slightly unusual position at the moment because we don't, they're much higher than they would usually be. So obviously different teams, you see turnover at different times. So I'll leave Charlotte to provide any further detail on that one, but I think it's not that we generally see that, it's just that we are seeing it at the moment. And in terms of other authorities, Charlotte mentioned before the pressure with the move to the social care reform and the number of new social workers we're going to need. Absolutely, other authorities will be looking at this, are looking at this and looking at how they do it. And so this is about getting ahead of the curve. We do know that the expectation is that there are more social workers needed than there are currently. And so this is going to be a continuing challenge, I think, for everybody.
Thank you, Charlotte.
Thank you, Chair, and thank you, Justine, for answering that question as well. Just really briefly, so Councillor Slatter, yes, if successful, we will need less agency staff. In terms of the question from Councillor Boulat about why some teams seem to have more difficulties than others, obviously we've looked at this. There does seem to be it's just a very uneven pattern in terms of different teams experience difficulties at different times. We always do exit interviews to check there isn't something more fundamental in terms of management style or culture or working environment. But our conclusion is actually these are hard jobs that people find very challenging, and particularly when you're working in the area of learning disability and autism at the moment, people's needs have increased as a result of the pandemic. Our providers are struggling to meet the needs of people with complex needs, and so that makes the job of a social worker, I think, that much more demanding and stressful because their focus is all about getting the right outcome for the person. Councillor Boulat also asked a question, I think, which was sort of, is this going to be enough, really? We did look at sort of less expensive alternatives to this, but reached a conclusion really that we need to future-proof ourselves, and for that reason that's why we've put this proposal in. I do think that when the new chief executive starts, there will be some things that we will have to look at in terms of the way in which the sort of pay and reward scheme works, and particularly whether we need to reintroduce increments is certainly one area that I think we're interested in, but will be expensive. So it's not going to be an easy one. But this is going to get more and more challenging in terms of the job market. And yes, Councillor van der Ven, you're absolutely right. We might have understated a little bit the challenges that are ahead in terms of the adult social care reforms, which is going to need really good social workers, and we're just incredibly fortunate to have the staff that we've got, and very, very keen to keep them, having found them.
Indeed, the recommendation is to agree the implementation of a retention payment scheme for adult social workers with an investment of 302,000 in the next financial year and a further 152,000 in the financial year following. Is there any disagreement about that? No, people want to put their hands up. So, do you want to vote in favour of that? I'm seeing at least one abstention. I'm seeing one abstention, but otherwise everyone else in favour. Thank you very much. Oh, I do apologise then. Those against, please show. Thank you. And any abstentions? So I misread that. Thank you for indicating that. So we got that correct. We now move to the third report, which is the urgent item, the allocation of adult social care Omicron support funding in response to the COVID-19 pandemic. That will be Will again, I suspect.
Yeah, thank you, Chair. And I'll keep this brief. So this is we bring this paper as an urgent decision. It is another one-off grant from central government to support providers, specifically with the cost of infection control measures. You'll recall that £60 million was announced back in December, and the local allocations and guidance was issued on the 10th of January. The allocation for Cambridgeshire is 581,000, or just over 581,000. And our recommendation is to distribute all the funds to providers as a full pass-through. Now, this is for all CQC registered homes, whether we contract with them or not, domiciliary care providers, extra care and supported living. I would like to draw your attention to section 2.7 of the report, where these grants are often come in at very, very short notice, and we try and turn around as quickly as we can. That they don't always match our committee dates, and we're therefore asking committee to delegate, when it's not practical to wait for the next committee meeting, to the Executive Director of People and Communities in consultation with the Chair and Vice Chair around the distribution of funds and these grants in the future.
Thank you, Will. Any questions? I'm just looking around to see, the only speaker I see is Councillor Wilson.
Thanks, Will. I don't have a feeling of how significant this grant is. It says it will be distributed on a per unit basis, but for the average bed or occupier or care home, is it a significant amount of money or not very much?
It really isn't.
Just hold on, Will, just in case anyone else.
Oh, sorry.
No. There isn't anyone. I'll just add something before you come back. It's enormously frustrating that we, together with others in local government, are pressing government to get this money, and then we get such late decisions. And this money goes back if it's not spent by the end of March. This is hugely disruptive short-termism from government. It's really valuable money, but they've got to be more realistic about the ability and capacity of local government, not just us, to be able to receive and act on these decisions. And they've got to give us a bit more long-term money and not just give us money for the short term. And we know the uncertainties of the pandemic, but to give us something that is only going to be there for 10 weeks, it's pathetic, and they can do better. But what our independent providers, I hope, will see is that the minute we get money, we try and get it to them, because their problems are now. Their stresses and strains are now. We've heard about the handbacks. And so I hope the confidence of the local market will be there in terms of seeing how we're dealing with this in an urgent way. But I hope that the government will also get the message, not just from us, but others across the spectrum of local government, that they can and should be doing better. Will.
Thank you. So in answer, Councillor Wilson, whilst providers will welcome the money, as has been said, it's very short term. and in the grand, just put it in perspective, it's in the grand scheme of things is 580,000 divided by, if you think of all of the providers, CQC registered providers across Cambridgeshire, is not a lot of money, actually.
I think that that answer speaks for itself, although Graham, remember, likes figures. But I think the answer is as comprehensive as we need for this decision. The recommendation is that the committee is asked to approve the recommended allocation of Adult Social Care Omicron Support Fund issued by central government on a one-off basis to cover spend from January 2022 to be spent as soon as possible where this grant falls in line with the conditions set, and to delegate future decisions relating to the distribution of this urgent government grant funding where it's not practical to wait until the next committee meets, to the Executive Director of People and Communities in consultation with the Chair and the Vice Chair. Is there any disagreement to that? There is some disagreement. Is that? No, you're supporting. Okay, anybody disagreeing or abstaining? No, that's agreed unanimously. Is the committee happy to, and thank you, Will, again, and Justine. Is the committee agreed to just note the agenda plan and the training plan? Councillor Bowden.
Thank you, Chair. On the agenda plan, I note that there are plenty of dates which are listed beyond February, but they're largely unpopulated, which is understandable. What I would ask is that the first item to be populated in each meeting is the COVID-19 update. But secondly, I note the frequency of the meetings continues to be the same as was set out. The very fact that we're meeting here today on a reserve date goes to show that the frequency of these committee meetings, being effectively once every 3 months, isn't sufficient for the business of what was 2 committees. And I would ask for you and the administration privately just to consider whether some amendment may be appropriate.
Both points noted. Are people happy to note both the training plan and the agenda plan? They are. That's agreed. We have to reconvene here at 1 o'clock, which is 40 minutes time for lunch. You haven't had a break, so I'm sorry about that. I hope people don't object, and please speak to me privately if there are any issues in relation to that. Please be on time at 1 o'clock for our very important health scrutiny element of the debate. The meeting is adjourned.
Hello, can I just test you can hear me?
Yes, we can hear you.
Great, thank you.
Can I test if anybody can hear me?
Oh, Sarah, I can hear you.
Well, that's good. I can hear you because last time I couldn't. Thank you.
So if you've got time to ring the vet.
Okay, thank you.
Jenny, just saying nice to see you. Welcome. Good afternoon. Welcome back to the Adults and Health Committee of Cambridgeshire County Council, and we move to the health scrutiny section of the agenda. Welcome also to those members of the public who are watching the live stream on the Council's YouTube channel, and welcome to our co-opted members from the different districts around Cambridgeshire who play a full part as co-members on this item. Councillor Wood from Cambridge, welcome. Councillor Wilson from Huntingdonshire and Councillor Every from East Cambridgeshire. As was said this morning, Councillor Clark from Fenland is apologising, and I also have apologies from Councillor Garvey from South Cambridgeshire. And those of us in the room will notice that Councillors Ambrose, Smith and Gay are taking advantage of the online facility that we're allowed to use for this afternoon. And Councillor Murphy, it's difficult to recognise someone who's not there, and they are joining us by online, as well as Councillors Wood, Wilson and Every. And I'll try and make sure that we have a balanced and fully participatory debate, whether people are in the room or joining us online. Can I just remind people again that if you're not speaking, please keep your mask covering your mouth and nose, that filming is allowed and recording is allowed as long as it doesn't disrupt the meeting, that mobile phones should be switched off or switched to vibrate, and that we are indeed live streamed on the YouTube channel of the County Council and recorded for subsequent posting on the County Council's website. The first item this afternoon is item 9 of the agenda, the neuro rehabilitation consultation. A document was circulated, again quite late, apologies, but quite late because the consultation was only announced this week. So I thank you for those that have fully read the document, but it is in was circulated, is in the document pack and on our website. And we've got Tracy Cooper, who's Service Director, Ambulatory Care from Cambridgeshire Community Services, and Matthew Smith, Senior Responsible Officer, Urgent and Emergency Care for the CCG, who are jointly presenting the report. Can I just check I can see Tracy and Matthew? I can see Matthew. Can I see Tracy? Not yet. If Tracy could put her camera on if she's joining us, or maybe she's not able to, but I'll ask Matthew to start off. Matthew.
Thank you, Chair, and good afternoon, everybody. My colleague Tracy Cooper is having some internet issues at the moment, but she will try and join us if she can. So, as you've said, we've just started a public consultation on some proposals around neuro rehab services, and specifically quite a specialist one called the Oliver Zangwill Centre. So I'll just run briefly through the key points that are in the consultation document. The consultation itself runs for 6 weeks. So the service that we're talking about is neuropsychological rehab, and it's targeted at patients who have an acquired brain injury, specifically after 12 months, when their needs tend to be picked up. The context of this is a review that we did in 2019 of all of our neuro rehab services, and those are set out in the consultation document in some detail. So Cambridge and Peterborough Community Services Trust provide a community neuro rehab team. Addenbrooke's provide neuro rehab services, and so does North West Anglia Foundation Trust, and there are also voluntary sector services that complement the statutory ones. So what we identified through that 2019 review were a number of areas for improvement and better integration across the range of services, but we also identified a need for more in-depth review of the Oliver Zangwill service. And what we found through that review is that it's a unique service which is not commissioned by other CCGs in England. What we've also seen over the past 18 months, 2 years, is that referrals have dwindled. And there's a table in the consultation document that shows that trajectory over time. And in this current year, there are 6 patients who have been assessed. And this is all in the context of Cambridge and Peterborough NHS being in very significant financial challenged territory, as you probably know. So we are in what's called level 4 nationally because of our financial challenges, and that's the highest level of concern. The service that's provided by the Oliver Zangwill Centre costs about £800,000, and in the context of what I've just described with the dwindling referrals and the financial challenges that we face, the proposal that's coming here in this consultation document is to cease provision of this service. What we can say, however, is that there are a range of alternative services which we believe will meet the reasonable needs of our population who do have acquired brain injury. So, as I've said, there is a community neuro rehab team which takes several thousand referrals. It operates a multidisciplinary approach. It includes speech and language therapy, psychology, and many other specialisms. So, in summary, the document sets out the rationale behind this proposal, and I'll stop there, and I'm very happy to answer any questions.
Thank you very much, Matthew. We've also got in front of us the public consultation paper, again, that was circulated to all members. I saw Councillor Slatter first.
Thank you. I'm really quite disturbed by this document and the attached survey.
We lost everyone.
It's the TV screen. When we get those messages, shall we come and shout to you? Because we've had the messages warning us.
Oh, there they are, sorry.
Just for people following us online, we've got some technical issues. The screens went off in the room, and I'm not sure that your microphone was working, Councillor Slatter. So we're just pausing for a moment to chat. The screens are now back with us. Could I just check your microphone's working?
Yes, is that
And
okay?
it is indeed.
Thank you.
Apologies for that slight interruption. Please continue.
I'm very disturbed by this document and the associated survey. It came very late, so I hope I'm not going to ask a question that it already answers. And my the Wi-Fi won't work on my laptop, so I can't check on the survey. But I do have some questions. I'm not quite sure from the report that I read what sort of organisation the Oliver Zangwill is. I mean, does it have its own staffing? Are there professionals involved in this who would be, looking for a job, that sort of thing, or are these all people that could be redeployed? That's one thing. The other thing that I'm most concerned about is the survey, though. I don't know how many members have managed to look at it, but it's, to my mind, an insult. It's rude. It starts off, as I recall, and I'm sorry I can't look it up and check my facts, with asking people, do you know why you're being surveyed? Correct me if I'm wrong. If I followed the wrong link, I apologize, but could we please check on that? Because this is not consultation. This is the delivery of a cut or a withdrawal of service and telling people a bit in advance. We already have in the document, I think, that the service will be withdrawn after a period of public consultation. Now, if the individuals involved are being offered all sorts of alternatives, fine. But I would like to know what the reason for the fall off is as far as the officers are concerned. If it was a matter of the Oliver Zangwill being a pioneer in the area and outside counties and insurance companies using it because they didn't have anything else, but now they are using other comparable services that are equally good, fine. Things move very fast in this area of treatment, we know that. So if it is indeed that we were ahead of the game and we no longer have the financial sustainability to continue having this service time, if the fall off is also because of COVID, and of course these people would have been some of the key people who are being shielded and told not to leave their houses, let alone go and be following up on assessments and even having assessments in the first place. I would like to see that in before I vote on this, because I fear we could otherwise be acting unjustly and hastily, and especially with such a short time to read the papers.
Thank you for your questions.
Matthew, I'm going to group together. By the way, Tracy is now joined us online, so thank you. You're very welcome. And I hope you heard that was the first intervention from the councillors. I hope you heard that successfully. I mean, it's going to take a round of questions, Matthew and Tracy, rather than asking you to answer them one by one. So if you can kindly take note of the questions. And again, Councillor Wood, if you want to raise a question, I can see your hand, you'll be on the speakers list. Next, though, I had, and I'm sorry, I need to go from the list I've got in front of me, Councillor Howell, please.
Thank you, Chairman. Chairman, I should start, sorry, I'll just take my mask off. Chairman, I should start by saying I spent 10 years working in a rehabilitation centre, offering many services, not all which the Oliver Zangwill Centre. I've never visited the Oliver Zangwill, much to the pity, but I can only speak of it as reputation, and its reputation is nothing short than excellent. It is been seen very much as one of the lead centres in the country. It offers a very specialised and a very unique and bespoke service, and I can only ever speak highly of the centre. Chairman, all that in case, I noticed a drop in numbers on figures. Rehabilitation and work in rehabilitation has taught me that majority, although not all, of the people who enter into rehabilitation have normally done through a workplace accident or also a car or more road traffic accident. Over the last year or two, of course, workplace accidents such as on building sites and everything have fallen because, of course, we weren't doing it. Many people were at home furloughed and not working at all. And road traffic accidents, thankfully, have fallen as well because of the same period. Therefore, that will naturally show, Chairman, that the figures will be much reduced to what they once were. With regards to what is on offer outside the Oliver Zangwill Centre, it's great to see what it is, but the glaring obvious one to me is vocational rehabilitation and that specialisation which the Oliver Zangwill offers to people to be able to help them through. £800,000 is a significant amount of money, but if these people who attend the centre do not have this treatment, they will cost considerably more in the future than £800,000 with the type of care that they're going to need. Let's not forget that everybody makes the majority of their recovery within the first 3 years of their accident. Chairman, I think there are many questions I would like to ask, and I would be very interested and hope that you would allow us to ask further questions further on this. I am very disappointed that this has come forward. One of the things, however, I just would like to ask, Chairman, as a very specific question, is that it is noted that working with insurance companies, the Oliver Zangwill has done in the past, and indeed they were competitors of the company I work for in that very area. When you work with insurance companies, they don't like to, but they are charged an amount. I don't see how much money was brought in by the Oliver Zangwill Centre to offset the £800,000 and whether or not that has been done. The problem we got is quite simply this. If you break up this centre, you can't put it back together. It costs far too much. And these people are so specialised, it will never happen again. And God forbid any of us or anybody that we should know should need it, because it is what I consider to be one of the best rehabilitation centres in the area. Although, as it says in the document, it can't be compared because of its specialised nature. Thank you, Chairman.
Thank you very much. Councillor Wood, please.
Well, Councillor Howell has asked some of the points I wanted to ask, but I'm intrigued. I mean, from this table, it's difficult to see how long, well, you can't see how long people are being treated for. And as it does seem that, as Councillor Howell has mentioned, that, you know, the first 3 years are key, and it wasn't too clear to me whether other places were providing exactly this type of treatment, whether or not costs could be reduced by moving it to another centre, such as Addenbrooke's. And certainly the drop in the number of patients being assessed, you know, which looks, you know, it has been falling, but those last two to 3 years of COVID are almost certainly going to have affected this. So if people are postponing their treatment, I think we sort of need to have more granularity about why that is. Again, I wasn't quite clear how specialist this unit is. Is anybody else providing this service in the area of Cambridgeshire and Peterborough? I've mentioned the costs, how long people have been treated. You know, there is often a difficulty that if you want patients to go to a regional centre, that can, of course, you know, introduce traffic issues and costs for the people trying to get there. So those that I think are my main questions. I do have a personal interest in this with a close friend, well, several close friends who suffered strokes, but it doesn't seem as though this is quite what this delivers. But with long-term, you know, like 3 years support, they've got back into working full-time. Thank you.
Thank you. 2 more speakers. Councillor Wilson.
Thank you, Chair. Many of my comments have been raised already, but I'll just quickly run through them just to reinforce. The first one is about the numbers of patients assessed and the extent to which that is related to COVID or not. The second is the impact on staff, and I think the paper refers to 24 staff. So will these be tupied across to other organisations, or is there an expectation that some or all will be made redundant? And if so, what will that cost? As far as I could see, there was no direct comment on the amount of money that was going to be saved by this change. The total cost is £800,000, but by the time you've made people redundant or moved them around, you won't save anywhere near that amount of money. And the final point is related to the consultation. I'm of the same opinion of Councillor Slatter that the decision has already been made and we're just going through the motions. It doesn't seem to me that any alternatives or proper explanation are really being made here. That may be the right thing, a right decision has been made, but I don't think that's what consultation is about. Thank you.
Councillor van der Ven is next.
Thank you, Chair. I think Kate Parker's on the line. Of course, were she sitting in the room, she might have given us an introduction about our scrutiny function, which I believe is around the consultation very specifically, rather than the decision itself, but it's the manner of, and it might be useful to have Kate's observations there, though of course you can't talk about consultation without the scope of what sits behind it. Anyway, I'll just leave that as a comment. And to say thank you for the papers. I know we are, they're not required, but they're very welcome and they help us to prepare for the item. I would like to acknowledge the really awful circumstances of the people who find themselves needing this service. And that goes without saying, but this is a very human story. It would be useful to know in terms of the drop in usage pre-pandemic that was noted, why that was so. And what went through my mind, given the long period of time in which this service has been around, have alternative services provided by the NHS evolved over time to be a closer match? You know, is that full holistic approach available through other channels? That wasn't clear whether that was one of the reasons for considering options at this moment in time, although I, of course, understand the financial picture. So it'd be good to have a picture, good to have a sense of that. And presumably there are aspects of the service which are unique. And as Councillor Howell pointed out, you know, the value of rehabilitation to society is really important, in addition to the person themselves, of course. But how else can any needs that are not replicated elsewhere in the system be addressed? And then just a little note, in case anyone from the Oliver Zangwill Centre is listening in, I did take a look at the website and I found a Fit for the Future link is a little bit out of date. And I mention that because we're looking at that at the moment in this committee. And I think that would be the ICS website now to replace Fit for the Future. So thank you very much.
Thank you. That's all the speakers. We've only got 30 minutes for this, so thank you everyone for being concise. If I missed someone, I did miss you, and I really apologise. Councillor Daunton.
Thank you. It's really just to follow on from Councillor Wilson's question and really on the figures. The Centre says the cost of this service each year is around 800,000. Doesn't give us the broader context. 800,000 from what? What is the overall budget? What is the overall savings to be needed? Could you give us the wider financial context? Thank you.
Thank you. Apologies again. Just to try and pull it together and to make sure that everyone's clear following Councillor Van der Vent's point, where we have a consultation, we have a debate like this as a committee. Kay Parker from our public health team is listening and note-taking the debate. That is then written up in the form of a formal council conclusion to the consultation. So it's not just the dialogue today with our officer friends from health, we also then formally write it up, although it's useful to hear some answers from Matthew and Tracy in conclusion. What I've heard is that so far members have not been persuaded that this is a change which is for the benefit of the service, but is really driven by financial saving. We haven't really heard what alternatives were considered and will be provided. We've heard questioning of whether the financial savings will actually be realised, and we've expressed concern, this is Councillor Howell, that if the service is ended, it won't come back, and a potentially very valuable resource and service would be lost. Matthew and Tracy, I leave it to you to decide who goes first.
Okay, thank you, and thank you for all those questions and comments, much appreciated. So just to start firstly by saying that this is a consultation about a proposal. No decision has been taken. Once the consultation has been completed, a report will be prepared for the CCG governing body, which will take into account all of the comments which have been made throughout the 6-week consultation period. The second thing, I think there were some questions about the staff. So there are a small number of staff involved here, and we will work very hard, subject to the outcome of consultation, on redeploying these staff within the local NHS. They have very valuable skills, particularly the therapy staff. They do a fantastic job, and we have a large number of vacancies in the local NHS for therapists. So that's what we will work on, subject to the outcome of consultation. Have we looked at alternatives? Yes, Cambridge Community Services did a huge amount of work looking at many different ways of structuring the service and the finances in the context of the dwindling referrals. And I'll ask Tracy to perhaps come back to that point in a moment. In terms of the numbers and the reduction in patients, I think there probably are multiple reasons. I don't think we can rule out COVID in the most recent years, but the reduction in referrals for assessments, you can see, began before COVID hit. And of course, whatever the reasons, we're still in a position of having £800,000 attached to this service for those relatively small numbers of patients. Tracy, do you want to comment on the work that CCS have done?
Yeah, okay. Can everyone hear me? I'm so sorry. I've had some real IT connection issues today.
We can hear you very clearly. Thank you.
Brilliant. Thank you. So can I just, before I do answer some of those questions, can I just thank the councillors who acknowledged about our staff and the way that the service has been highly valued in the past. So thank you for that, because we value the staff greatly. And going back to Matthew's point about us working really hard, if the outcome of this consultation is that the service ceases, that we are absolutely committed to making sure that those staff find the appropriate place that they can, because they've got some amazing clinical skills to actually have in our system, and we're very lucky to have them. So just to give you a bit of context about the work we've tried to do internally, because we obviously recognise that £800 is a significant amount of money. And when you look at the dwindling patients that we have had coming through, we've done some work to try and really think about, could we restructure the service in any way? So we've had several goes at trying to do some service redesign. But what we get back to each time is that we need those different clinicians and the skill sets that they bring. So that obviously then gives us a critical mass of staff that we need to be able to provide the service that the Oliver Zangwill has been providing in the past. So just to give you a bit of an idea, because one of you did ask about how long a patient's treated in the service. So the service has a holistic programme, and you'll see from the table that we've had dwindling amounts of patients coming through. So in the last set of the last year, we've had 6 patients that have been assessed that could have gone on to the holistic programme. That's an 18-week pathway with several practitioners that would work with those individuals. So you can imagine that that's quite an expensive way of providing care, but obviously for those patients, that's been the programme that we've offered. So it's quite a significant amount of impact that goes into those few patients. The thing that we have really struggled with, we've done a lot of work looking across the country to see why the numbers have fallen. And in being really honest with you, I don't know why that is. I think one of you made a point about has other services evolved across the country? And I think they probably have. And I think that there will be different services provided in different areas for patients, and hence why we're not getting so many of those insurance activity. That is now zero for us. 5 years ago, we would have been able to supplement the 800,000 with some income from insurance-backed patients, but that is not the case any longer. So we're left in a situation where we couldn't reduce the service any less than the 800,000 it costs at the moment to provide. Is there anything I've missed from the questions you asked?
I think there's been a good exchange, and you've been as comprehensive as you can be. I think you will find that there will be some questioning responses when we make our formal response after today, but I think your participation is very well informed the committee, and that it's the sort of dialogue that we should be having over what we appreciate are extremely difficult decisions. There's no closure anywhere that's not going to be sensitive and difficult, and I think we've illuminated the questions as well as possible this afternoon. So I'm afraid that the other guests are already waiting for us online. So I thank you, Tracy and Matthew, for contributing, and we look forward to writing up this afternoon's debate as a
She didn't answer my
consultation.
question about the survey, and that is what we are being asked to scrutinise.
Okay, I
Sorry.
see you're, no, don't apologise. I understand you feel strongly about it. Tracy, can you just respond to that point?
The survey, so Matthew, I think you need to respond to that, don't you? Because
Yeah,
sorry.
So I'm very happy to pick up any specific considerations about the wording of the survey, but I would just repeat that this is absolutely a genuine consultation, and all of the comments that come back through the 6 weeks will be taken into account by the governing body in a full and detailed report.
Okay, I will just ask. Okay, I will just ask Councillor Slatter if she wants to make a short response on that.
As the Wi-Fi doesn't talk to my laptop, I cannot quote to you the questions in the survey that so disturbed me, but they're just the preliminary one. I don't know who designed it. It can be changed very quickly as it's an online survey, and I would urge you to have another look at it if you didn't design it, and I'll be happy to exchange emails once I can get back and look at the original, and we can leave it like that.
Thank you.
Okay, I think that's a very constructive suggestion, and our Democratic Services Officer, Tamar, can assist in ensuring right emails are exchanged to enable that conversation to happen. Matthew and Tracy, thank you very, very much for your time and your contribution this afternoon. If I can invite John O'Brien and Jan Thomas to put your cameras on and to join this afternoon's meeting. You're very welcome. I also just want to say we've got Councillor Every, you're welcome, now joined us. Councillor Murphy has been there also. And if both of you would like to turn your cameras on, then I will be able to see you more effectively. So it would be great if you were willing to do that. I think we also have a number of our officers, including our Director of Public Health, Director of Commissioning, Kate Park herself, who supports us in our scrutiny function, all online and participating, but not in the room. Welcome to all of them. Oh, Councillor Sarah Wilson, I apologise. Councillor Sarah Wilson, thank you. And again, Sarah, if you could kindly put your camera on, again, that would assist us. So we now move to the main item for this afternoon, which is the integrated care system for Cambridgeshire and Peterborough. It's item 10 on the agenda, and it's pages 95 to 106 of the agenda pack. I welcome sincerely Jan and John. Councillor Van der Ven and myself have been meeting with you, and also the interim chair, John, before you came, Mike Moore, I would say every 2 to 3 weeks over the course of the last 6 months. So we've all been getting to know each other very, very well. I'd like to warmly welcome you to this public committee meeting of the County Council and start by thanking you for the time and effort that you put into dialogue with ourselves and our officer colleagues. And there's obviously a rich and constructive relationship between us, and I really welcome that, and it's great to have an opportunity to say that and to demonstrate that in a public committee meeting this afternoon. The second thing I'll say in introduction is that we in Cambridgeshire are part of a third wave of the ICSs. In some ways we're late, not by local decision, but by national decision, but we've been able to learn from other areas. But we've also had, and you've also had, Jan and John, an incredibly short and tight timescale to do some really, really unbelievably complex things, and we'd be pleased to participate with you in that. But we just do recognise that, and we also recognise that many of our discussions over the last months have not been about ICS structures and governance. They've been about the pandemic and the utter brilliant, superb, fantastic provision that has been made by the Health Service to support local people in our county to get through the pandemic, and which continues day by day, hour by hour. And it is very proper for us to open the meeting by saying that and by thanking you for it, and to understand, I'm sure we'll come back to this in questions, that will take place, that is taking place, and huge financial pressures that you're having to grapple with at the same time. And the final thing I'd like to say in introduction is that, as I said to you in the run-up to this meeting, and Councillor Van der Ven and myself have said to you in the run-up to this meeting, we recognise this isn't a conventional scrutiny item on the committee's agenda as it would have been perhaps 5 years ago or even 2 years ago, because in the ICS we're a partner, we're part of delivering this with you, and so we're not looking on the outside and commenting on what you're doing. We are working together with it, and that needs a more advanced, developed and mature role for us on the county council side as well. And I hope and expect that the tone of this afternoon's debate will reflect that we're welcoming you for the crucial work you're doing, but also as our partners in a joint endeavour. So having said that, I'm delighted, I suspect John first, to ask you to address the committee.
Chair, thank you very much indeed, and thank you for those opening remarks. And if I can reciprocate by saying that in my brief time as the chair designate for the ICS, I've really valued the interaction that we've had with yourself and Councillor Van der Ven, and also lead members from Peterborough covering the whole system, as well as officers who've been really constructive and really helpful. And I absolutely share the points you've made about us being on a partnership journey together, which we are mutually dependent on each other, I think, to make progress. And I'm really pleased by the way that we've started that. I've been the chair designate of the integrated care system since about the middle of November, so I'm in the sort of middle of an induction period either side of Christmas. So unsurprisingly, I will ask Jan Thomas to speak to the paper in a moment in terms of some of the detail of our preparatory work. We are due now to become a statutory body on the 1st of July this year, originally the 1st of April, but nationally a decision has been taken to delay by 3 months. I think given the sort of progress of legislation through through Parliament, and I guess to some degree impacted by COVID pressures as well. I think probably all of us would share a strong sense that the potential for a more population health-based approach to health and care is important, that we share, I guess, a strong commitment to tackling health inequalities and to seeing the potential for how together we can make health part of a broader social and economic development component of what we do in terms of serving the communities across this patch. And all of that, of course, vitally depends on a sort of key contribution of a whole range of partners, not just those in the health service. And local government obviously is sort of vital to that. Some of you will know that my own background is primarily in local government as opposed to health, but that contribution, both in terms of service delivery responsibilities, most obviously around adult social care, but clearly also around housing and around children's services and education, but also that wider economic development and social and economic development piece. So I think that's obviously an important part of it, but also, and critically it seems to me, I recognise your role as conveners and leaders of places and of communities, and the insight that you all bring to individual communities right across Cambridgeshire and Peterborough, and the knowledge that you bring. And it'll be very hard for us, it seems to me, to make progress on the sort of objectives we share unless we're able to recognise that and make use of it. I think that this is a serious attempt, I think, to address some of those shared objectives that we all have. Not just structurally, although we will talk about that, I'm sure, in terms of the integrated care partnership and the board, But I think in terms of what we can do practically about out of hospital care and redesigning pathways, in terms of tackling inequalities, and in terms of putting a real emphasis upon place and communities across the piece. And I think all of those are central to the ICS development. We, of course, face together, I think, some big challenges. We've already talked this afternoon, or you've already talked this afternoon, about resources, and mention has been made of the financial challenge that the health system faces across the patch. But I am also conscious of the pressures on local government as part of that wider piece. COVID clearly is going to lead to some significant pent-up demand, and as we've seen across the country, a further challenge in terms of health inequalities, and adding to that. But I think from what I've observed in my very brief time, the partnership has, as you said, Chair, worked very constructively together through the COVID period. So I think it has that to build on as we move towards full statutory status. And I think also a sense that our shared future, in terms of the ambitions we all have, can only really be achieved if we work together on some of that shift in care that we've spoken about. And so I look forward to doing that. You've got a paper, or you have papers, I think, which reflect the progress we're making. But perhaps I could ask Jan Thomas, who's the Chief Executive Designate of the ICS, to talk a little more about that. Jan,
please.
Yes, thanks, John, for that. And I think it is important, I think, to recognise that whilst we are sitting here going to talk about new ways of working, that over the last 2 years, the extraordinary progress, I think, that has been made in the most difficult of circumstances we could have ever imagined, about how across health and care and the wider integration with local government has really been very, very strong. And personally, working with colleagues across health and local government in things like the incident response and the degree to which the mutual aid has been delivered, and the way that we have all pulled together and lent on each other, I think, through these very difficult times to support both our residents and our staff, has been extraordinary. And I think that's the foundations we really want to build from. And I think once we've all had a flavour of what it feels like to really work together and be able to support each other in a different way, the ICS, I think, gives us a fantastic opportunity to just kind of supersize that and go further faster. So I think it's really, really exciting times ahead. And so what is going to be different, I think, is the key question that everybody wants to know. It's a bit of a so what, isn't it? You know, we're in this position where, you know, there's a new legislation coming in, there's a whole load of governance change, but so what? I think the so what is huge for us. So previously in health, so for those that I've met before, I am also the chief executive of the current CCG in Cambridgeshire and Peterborough. And previously, what I would say is, by the nature of what we were asked to do and our statutory responsibilities, that was has to be quite a transactional organisation. It's about what services in health we provide to people in order to meet the need that they are presenting with. It also, in the way that the health service was set up, was very much kind of commissioners have control over the money, and the providers, we have to put contracts in place, and then we have to do what, you know, the commissioners have asked. And I think over the years, what we've all realised is that role of really looking ahead and working out what the population need is. Needs to be far more strategic, needs to be far more, as John said, based on population health, and far more personal to people in the communities than they're in. And I think that's really at the heart of the so what's different, because the ambitions that we've got in the ICS start with how do we really impact health inequalities for the longer term? Because if we're going to deal with the problems we have in health, we won't do that by just putting on more of everything consistently over time. What we need to do is get to the heart and get into alongside public health colleagues, which is what is making people more sick, what is causing them to need more services, and how do we cope with the kind of great situation that people are living longer, but how do we ensure that they live longer, I can say more well? And how do we do that in a way that the health service doesn't become paternalistic in that, in trying to tell people what to do, and how does it empower people more to do that? So our first priority and what we want to do differently is very much have a focus on what we can do around health inequalities. And by that is about us being far more specific about how we provide services for real communities in need. So some people might be aware that we've done a little bit of this already in the diabetes program that we provide, where we actually segmented the whole population out and really targeted resource and people and services where we knew the prevalence was high, but the pre-diabetic prevalence was high, and not just the prevalence of diabetes. And we've done a very, very targeted approach. But that won't solve all of our long-term problems. What we need to do is say, in health alone, we employ 1 in 25 working age adults in Cambridgeshire and Peterborough. That's what we employ. So we can have a big role here in how we offer our second priority, which is opportunity. So how do we, through health, what we can offer with having access to things like the extraordinary biomedical campus that we've got in Cambridgeshire, really offer our local residents an opportunity to get into good employment that raises the standards, that increases their ability to access better, for example, housing, that will provide them the factors that will really deal with the wider determinants of health. So the so what is about, we are still going to provide world-class services, but we want to do that in a way that gives people much more control over them, over what they're doing, but also make sure that we're providing our residents with the opportunity. So it's going to move from being still focused on the detail, but really looking at what our role is to make sure that we can deal with those aspects for the whole of our residents a little bit differently. And then we could say, but what does that actually mean? Well, what we are going to do is we are going to effectively set up 6 different groups to work at making sure that we are dealing with all of those issues and providing world-class service. The first thing is that we are looking to become far more place focused. We've kind of clumsily called it north-south, but what we're trying to do is we're trying to build communities around our GP groups that are now working as primary care networks. We have 21 of those across Cambridgeshire and Peterborough, and we want to use those as the hubs, integrating with care to make sure that we can provide local services. Those 21 PCNs will then work as part of a north and south, where we can provide far more localized view to what we're doing. We also want to give dedicated time and resources to 2 other very important areas. That is mental health and LD. I think we should all be, we've all seen the increase in demand in mental health, but also the area that certainly keeps me awake is what are we doing with our learning disabilities population? Are we doing as much for them as possible? And are the outcomes that we're achieving for our learning disabilities where they should be in the longer term? And we think that there's some work to do there. So the third group, that we're working through is the mental health and LD collaborative. And then lastly, we are creating a children's and maternity collaborative. So north-south, mental health, learning disabilities and children maternities are deliberately called collaboratives. What we are going to do is we are going to, through a good, strong governance process, devolve accountability and integrate as much as possible with local government services, so that we can provide single capitated budgets to make sure that we can deliver the right outcomes for patients. So if I can put this mildly crudely, we want to stop counting the widgets of how many things are we doing and really concentrate on the impact. And instead of trying to do that alone, kind of do that much more hand in glove with our partners. There are two other areas that are really important to us, which make up buckets 5 and 6 of our ways of working. In Cambridgeshire and Peterborough, the budget that we get into the CCG for health is only 1/3 of the health income for Cambridgeshire and Peterborough. A big chunk of that is actually because we have 2 excellent world-class facilities that provide specialist and tertiary services. That is really important to the sustainability of our providers. And I was interested in listening to the debate of Oliver Zangwell, where you talked about income and how we offset. Well, specialised to us for our health financial economy is very, very important. So we want to make sure that we are still able to provide those excellent specialist services through unique assets that we have here in say, for example, the fabulous clinicians we get through Cambridge University. And then if we're going to get all of this right, the sixth unit that we're going to create is around strategic commissioning. And that's really about, instead of us talking about what we're going to be doing this year, I want to be sitting here talking to you about what we're going to be doing in 2 years' time to 10 years' time, and actually get a much more long-term view. I've always been envious of how local governments can do planning further in advance than maybe health services do. And what we want to do as the integrated care system is really get ahead on that and get a better way of using population health data. So some real examples, I think, are helpful as what all of that means. So, okay, so you've got big ambitions around health inequalities. You're going to set up a different way of working, which is going to move care much more local and much more focused on those specific areas. But you kind of still come to the so what. So if I can concentrate in the paper with the examples that show you the kinds of different approach that we want to take. So we have recently won a national award for the work that we've been doing around our end-of-life services. So what we have done is by working much more closely with the voluntary sector, we have integrated the voluntary sector and our 111 provider to provide a service for people at the end of life, so that their families or their carers at any time can phone 111 and press option 3 to get access to end-of-life advice. That is really a cross-sector piece of work that particularly with the input for the voluntary sector is providing families, patients and carers with a huge amount of support in a very different way than we would traditionally have done of looking at NHS providers and how we deliver that healthcare. If we look down at the work that we have done and what we have launched now around the Health Inequalities Challenge Prize, so we all know in health that a lot of things that health hasn't been embracing digital as much as many other sectors, but it would be very dangerous to do that without realizing the impact that digital poverty has and that not everybody can access digital. And therefore we have launched in partnership with colleagues in Healthwatch and Cambridgeshire Community Foundation a challenge prize, which is really asking people to come forward with ideas and ways to solve that or make inroads into that digital poverty, so that make sure that as we're putting on more health services through digital mechanisms, that digital poverty is being addressed at the same time. So that challenge prize has been launched. We've had a number of people come forward already and saying, yes, we can help do this differently in order to make sure that you can deliver health services more successfully. If you also look at what we have also set forward in terms of our urgent care waiting room, actually how we use the technology to make sure that rather than people sitting in facilities, that we can provide them with accurate times to come in and be seen by people, to have a better quality of service that runs them more efficiently. Again, that's an example of how we're trying to work very, very differently in the future. So we're trying to do all of this, but there is a hard edge to it. As John says, as of the 1st of July, we become a legal entity. That legal entity has the statutory responsibility for all of the same statutory responsibilities as we do for the current clinical commissioning group. And it has to take on additional responsibilities for planning and dealing with population health, for overall workforce strategy and the overall financial position of the healthcare system in Cambridgeshire and Peterborough. And the difference there is previously I was accountable for the CCG part of it. Now John and I become accountable for the overall financial position, including all of our provider colleagues. So statutorily, this is being put on quite a substantial footing in what we're trying to do. I think what's really exciting to build on all of those elements that we've talked about is that we are also working very carefully and I think really well with colleagues like Jyoti, Susan, Richard and Eileen, as we've said before, in terms of what we are doing to make sure that we are aligning what the Health and Wellbeing Board objectives are and our objectives. And that's really exciting to get to a core agreed. So there was an excellent workshop in October where together we agreed what 4 potential priorities could be to increase the health and well-being of our population. And ordinarily, of course, what would have happened is there would have been a Health and Wellbeing Board set of priorities here and a health set of priorities here. But we've agreed a joint set of priorities, and there is a further workshop on Monday to see how together we can make real tangible progress on those. And I think that's at the heart of what we're trying to do here. We're trying to bring together previously things that would have worked separately to accelerate the results for our residents on both a statutory footing, but also on a philosophical footing of how we need to do this differently to get better results. John, I'm not sure if I missed anything, but do tell me if you think I did.
No, I think that's fine, Jan, and very happy to discuss with members. Thank you.
Thank you warmly to you both. I think you've really introduced many issues there. If I wanted, we'll have time. We've got about an hour to do this, so I think we can do it justice. I'm going to take a different approach to calling members than we would normally do in this committee. What I'm going to do is we'll take whoever indicates first, but then we'll try and bunch other questions around the same theme that person has raised. We'll then ask John and Jan to reply, and then we'll move on to another contribution, another theme, so that we can have themed questions and answers rather than just scattergun. So I hope that'll be okay, but I will be happy to I actually think, Susan, you should go first. Is that okay? So I'm going to ask Councillor Van der Ven to go first.
Thank you very much. We feel quite steeped in ICS and really appreciate the enormous support from yourselves and your colleagues, and of course from our own officers since the joint administration took responsibility, and we've been learning and learning and learning. Ultimately, of course, this is about people, and you said that this is about the person and what will be different and why does it matter. I will therefore start with the people who are looking for that seamless experience that's referred to in the paper. And we do have anomalies in our system. We have an anomaly that may carry over from the previous CCG era, which is our borders. And in the papers, you do note that North Herts District Council is one of our 6 district councils. Cambridgeshire has 5 districts, but we've inherited a bit of a neighbouring authority, and that is just an administrative anomaly that I think we need to be mindful of, because it will impact on sort of full attention to people who straddle those services and that border area. And it's not for today, but we will have some thinking to do in terms of governance. North Herts District Council does not come under the Cambridgeshire Health and Wellbeing Board. It's the Hertfordshire Health and Wellbeing Board. So we've immediately got issues there that we need to be mindful of. And I know that local members do take up a lot of time from the CCG in putting their questions forward about residents who are caught in these borders. And Cambridgeshire is landlocked. We've got a lot of borders. So that's just to flag up, and it'd be really good to have a clearer understanding of that. And then I wanted to ask about, do you mind if I just look at my list here? Because I've got three themes, better themes. That
Are
was
either to do with borders and lines
No.
on map? Why don't we
Okay.
do borders and lines on map first, and just see if any other members, I'm looking also at councillors Murphy, Wood, Wilson and Every online. Does anyone have any questions on borders and lines on maps? Yes, councillor Slatter.
Yes and no. One thing, thank you very much for all that. I'm very glad it's recorded because I'm going to have to listen to you all over again, I think. The borders on maps, I know you know about My Cambridgeshire. Let's have them there so that the councillors, they get somebody come into a drop-in surgery and they can work out which PCN they're in and therefore which district council they're in and see if there are any border issues for us in that regard. The other one that I was going to ask about is more of an administrative border, and that is housing, because obviously we might have been able to deliver more in the way of cooperation as local authorities in housing, at least the district councils could have done, but we have a lot more housing associations now. And given that there are often health issues there's social care issues, some of the housing associations specialise in particular sort of sheltered housing and so on. We can't have everything under the ICS, I realise, but that is a border we need to be mindful of, to take Susan's phrase. But as I say, I'm very glad, Ms. Thomas, that you're on record. Thank you very much.
And just to add, Jan, a North and a South Alliance is not really very local in Cambridgeshire terms. Is it just not going to be another big bureaucracy? And if it's being run, each is run by a board of officers from both sets of authorities, is it going to really be accessible to the public and to people in, you talked about what we absolutely agree with in terms of neighbourhoods and people-centred and building up from the bottom. But the Northern Southern Alliance just look like conglomerations, I think, from the outside. Well, that's the danger. So I'd like you to pick up on that as well. What I'm suggesting is that we try to have relatively quick interchanges, the councillors as well, and then we can get through as many issues as possible. So John or Jan, you decide who wants to come back first.
Shall I just come back on the specific of the border? So I think there is we're absolutely right. We have an anomaly with Royston. We've been very, very conscious of that anomaly. And we're absolutely right. We have to make sure the links with the Hertfordshire Health and Wellbeing Board are right. And there are some specific challenges that I think we're all aware that we face with Royston, particularly with access to primary care. There's been some fragility in primary care, and there is a large growing population there. So, and it does cause some complications. But I think it causes complications for any patient that sits on the boundaries of lots of different areas. So we have lots of cases, for example, where people might be registered with a GP in say Norfolk or Hertfordshire or Bedfordshire, but actually live with us and with health. Of course, we work off where people are registered. Within local authorities, you work off where people live. So we are quite familiar with dealing with borders, but it is particularly difficult for people who live on those borders. So I think it's absolutely right that to raise it, to make sure it doesn't drop off our radar. I think when it comes to the north-south, I think it's absolutely right. What we're not trying to do is effectively create another layer of bureaucracy in the middle. What we're trying to do is say the local neighbourhood teams are the really key thing that we want to drive, and we've got our 21 primary care networks, and the comment is absolutely right. They may well feel quite irrelevant to some people that need a map to say, what is my PCN? Because what people recognise is their local GP service. They recognise the surgery, they recognise their community pharmacy, they recognise the voluntary services in the networks they've got around them. So we want to build up from those. And interestingly, what we are also trying to do is make that easier if I just talk from a purely health point of view at the moment, for the GPs to work a lot more with the hospitals and the services that they provide. And that's where the advantages in lots of places of north-south comes in. But what we are not doing, and we've made an explicit decision on this, which is we are not going to build new layers of bureaucracy to split the patch in half, when we can do the same thing by either using the principle of subsidiarity, where it should go down to the neighbourhoods, or there is no added value in splitting it in half and that we should do it once. So if I give you a real example, we've been doing lots of work in the last, consistently for the last 4 years, but a lot of work hand in glove with our social care colleagues to make sure that we can discharge people from hospitals appropriately at the moment because of the pressures we've got on hospital beds. Even though that is being run effectively through the north and south, they have agreed one lead and the teams meet once, and that works once, so that we can understand the differences between what's happening in the north of our area compared to the south areas. So I hope that answers the question. We do understand it's a bit of an arbitrary line, but to give us a way to split, to think about capitated budgets, for example, and it's that configuration of PCNs that we're thinking of, but very conscious that we don't want to put in just another layer that doesn't add value. We need to think neighbourhoods, and we need to think efficiency and productivity for scale.
Councillor Slatter's question on housing, Jan or John?
Yeah. John, did you?
No, I mean, I think Councillor Slatter absolutely right that we've got to obviously think about who is affecting these services on the ground, and housing associations and registered providers, are really important as part of that. We obviously need to have that relationship through those housing authorities, in particular, district councils, to actually make sure we're having that dialogue and discussion, but we certainly shouldn't miss them as part of that wider debate.
Thanks. I've got a note of Councillor Van der Ven's other points, so I'm going to integrate those through, but I also trying to get as many members in as possible from all sides. So I'm going to take Councillor Murphy next, please.
My question is not about boundaries. Is that all right?
You get to introduce a new theme.
Coming back to the question, the sort of rhetorical question, so what? Obviously, there's lots of potential there, and lots at population level, which is obviously very exciting for a lot of us. But I guess in the spirit of slight challenge, I would like to ask what you would say are the highlights, really, from the point of view of the individual, the patient or the resident, a local resident. What changes are they going to see? What are the benefits they are going to perceive or feel or believe? How is it going to affect them? I mean, there were a number of points that you made, Jan, in particular, that were sort of really were potentially answering that, but I just wonder, what if a resident or say a patient would say, well, what's the change going to mean for me?
That's nice and
Yeah.
That's nice and clear. In 12 months or 24 months, actually, for a citizen, what's it going to look like differently? I'll invite other members to contribute if you want to ask questions around local neighbourhoods and place-based. I think we can group those together. Councillor Wilson.
Thank you, Chair. Well, my comment follows on from Edna's about so what. And Jan, you talked about moving away from a transactional model, and I'll come back to that under a different topic. But picking up on what the Chair has just this moment said, how long is it going to take for all this lot to bed down, and when will patients and staff and others begin to see the real benefits of this? I don't know whether Councillor Bowden is on the call now, but he was saying this morning in relation to a different paper that we've seen numerous health service changes over the years. How do we know that this one is not just going to be another waste of money and we are really going to get some benefits out of this. And the government or another government is not going to come back in a couple of years' time with yet another proposal for another reorganisation that's going to shake up staff yet again.
So we're also building timing into this set of questions. Councillor Daunton.
Yeah, thank you. I'm not sure if this is within your section of questions, Chair, but you can stop me if it's not. Really, it's an extension of the housing issue. And that is the role of district councils, a really important role of district councils, not just in relation to housing, but planning as well, planning for new developments and new healthy developments. And then linked to that, the role of the voluntary organisations and linking that in with the ICS.
Thank you. That was absolutely a place-based question. And I think Susan had a place-based question, so I will ask her to address that. Councillor van der Ven.
Thank you. Yeah, I think you call it subsidiarity. Richard, you probably do with your European Parliament background. I think we call it decentralization. It's called getting local, right? Is that what you mean? So, yeah. Obviously, the local authority and all of us sitting around the table are really, we're accountable to local communities. And so we're really keen and passionate about that realm, and there's a huge amount of work to do there. Can you just say a little bit about, when you look at us, what do you see our contribution being? Okay, the districts are going to have to be involved, aren't they? They hold the housing remit. If we're talking about inequalities and jobs and housing, we need we need local government involved, and you've got this bureaucratic challenge. But what do you see when you look at us, around subsidiarity?
And subsidiarity, of course, means so that it's the most local level as possible in every case. That's what it's about, and I strongly support it. And it's in our paper and yours. So we've really asked there about how quickly it makes a difference, how it will be visibly make a difference, and how local government districts, as well as counties and upper tier authorities, will be associated with this. Back to John and Jan.
Shall I kick off and then pass to Jan? So I probably should have said this in response to your earlier point, Richard, but if subsidiarity or decentralization only goes as far as the level of North and South Place, then clearly we've failed. This has got to be about engaging people at a much more local level, at community level. In response to Susan's question, I think what do we look to? I think I go back to what I said at the start. It's a critical contribution in terms of a whole range of service delivery responsibilities which go both across the county council and districts and unitaries. So yes to planning, as the councillor said, as well as to housing, wider economic development, as well as some of your mainstream functions at the county level. But I think it is also, though, absolutely vital that we see local government as the key player in terms of convening and leading some of those local places, and the relationship that you have with communities, which I think is a unique one, and the insight that you bring. So I see those two dimensions as being really important. On the question about what will make a difference and over what time, I want to be realistic. There is a lot to achieve just by the 1st of July in terms of getting this body or bodies up and running, and we need to do that in a safe and legal way. And as Jan said, there are a whole series of still, pretty onerous statutory responsibilities just for the health part of the system. So, that is going to consume quite a lot of time and attention. But we've got to quickly, I think, as a partnership, move on to the agenda about what it is we agree we are seeking to change, and how individuals, going back to the question, what would they feel to be different over time? I hope they think that services are more joined up and more integrated. I hope they think they are closer to them in a way that is sensible geographically. That's not always about it being absolutely local, but it is in a sense about what makes sense to them. And I hope they think that over time, they can exercise more control over how those services get shaped and delivered. As I say, not all of that will happen at once, but we've really got to sort of be sure that we are transferring safely this spring, summer, and that we then are making real progress over the next 12 months towards some of those objectives. Jan.
Yeah, so I think that's summing up that is there, that says we want people to be, we want our residents to be in control of their healthcare, not waiting to hear what healthcare is going to do for them. And I think that's quite a big long-term ambition. I also think for in the short term, making sure we've got the access right, so that when people need their healthcare as locally as appropriate, we can provide it, and they can get it, and they can get it in a timely manner, and an easy way, I think is really important. I also think, if I think about specific examples about how we want to work differently, I can't think of a better example than actually the vaccination programme, which has been hugely challenging, because what we wanted to do with the vaccination programme was we provided a very much, if I just walk through the methodology, and hopefully this helps. So previously, when we've done services in the past, what we've done is we've said, we need a service, we need a vaccination services, go forth and do it. This time what we did, we said, actually, who needs it first? Where is the risk? And how do we make sure the most vulnerable get it? And so, however frustrating the cohorts that came about when people were coming forward, that was very scientifically driven, that says those that most in need must have it first. And I think that's a good, strong principle. Then we had to say, okay, so how do we make sure the access is right for that vaccination programme? So we started off thinking about scale and mass vaccination programmes, and we realised the GPs were the linchpin of it. The GPs stepped up and did a fabulous job of really engaging with their communities that they serve. And then we worked hand in glove with the local government, where we said, actually, we don't know the communities, you know the communities, can you help us really make sure that we're getting the right people into the vaccination centre? And then we got, we put the vaccination programme onto wheels and started putting it in a bus round, going to people, not waiting for people to come to us. And I think those principles of what we tried to do for the vaccination programme really highlight what needs to be different for people, which is, it might be quite difficult for people to understand, but it's not going to be about everybody getting access to the same thing. It's going to be those that really need it getting access first. It's going to be about that being available locally, and us being nimble enough to say, if you can't come to us, how do we come to you? And when is it right for us to come to you? And how do we make that as simple as possible? How do you make that one email, one phone call, one quick access point, so you could walk away today knowing who you're going to see and when you're going to see them? And I think, that for us, I think really encompasses what people should expect. Now that doesn't always please everybody all of the time, because it does mean that there will be variation, but the vaccine model we had to deploy, say in Fenland, felt very different from the vaccination programme we had to deploy in the centre of Cambridge, and doing that differently because that's what local people wanted is the key that people can expect. So it won't be all the same going forward. And if I could just go to Susan's question just very, very briefly. The key, if somebody said to me at the minute, what's the thing you need more than anything, I would say workforce. The key to workforce is getting people enthused about careers in health and care from a young age, making sure they've got the right educations, making sure we're getting them as able as possible when they are entering education and exiting education, to then come forward to provide the future pipeline for us in healthcare in what we need to build as a range of careers. So I think we need to take ourselves a real ambitious step forward and say what we need from local government isn't just could you help us with social care and education? It's how do we get the pipeline of people? How do we get the right green spaces? How do we get the transport links that means that somebody in Wisbech can get to a job on the Cambridge Biomedical campus going forward? And how then, for example, if the biomedical campus want to develop something, we can encourage them to do that in Ely, for example. So it's that real kind of intricate strategic links that we need to make and work with you on, as well as what we're doing for individual people on a care package basis.
And in case we don't get time to talk further on that issue, we've already indicated in private that we want to do more work with you on workforce development. We've got the same challenges, the same labour market, and you've got a very good working group within the CCG, but we need to be more joined up with it. And so just signal that's an area we want to do much more work with you on. Councillor Wood, could you just, we've probably got 2 rounds left, so I want to make sure we hit the major issues. What's the issue you want to raise, Councillor Wood?
Firstly, from what you've just been.
Could you just tell me the issue?
All right.
And then I can see how we can group it.
Resources and the resources that are needed from local authority districts.
That's quite a specific question. So what I'm going to say to the whole committee is things that we could do on things that are to do with finance and financing the ICS. So I will invite any questions on that, starting with you, Councillor Wood.
Well, actually, this was it's staffing and the resources and input that you need from local authority districts. Because it is quite heavy, and it's also drawing staff and who know about things across different departments. So it's unsiloing things, if you like, but getting that fed into you, what you need, Jan, and then it's the strategy and what would that look like? I know that's not necessarily about finance. I can see that you'd be working very closely with public health. And I just want to say, when you're talking about the vaccine programme, that is one project, or Cambridge, it's been one project with a larger programme. But here we're talking about things that are crossing so multi-stranded. It's how you're going to manage that. As I say, the resource that's needed from hard-pressed councils at the moment. Thank you.
Okay, well, on strategy and the role of public health, we'll perhaps come back to that. So let's just park that for a moment. It's been heard and noted, though, Councillor Wood. On finance, and as you probably say, that resources are people as well as money. Have I got any questions? People online are welcome to wave at me. Any questions on that? Councillor Wilson.
Well, I've got a question about identifying preferred providers. So that's more a contractual one rather than a financial one. So can we?
Yeah, go for that.
Okay. Jan, could you tell us a bit more how preferred providers will be identified and how long it's going to take to do that? It makes eminent sense that people like CPFT should provide mental health services, and Charlotte this morning talked about CCS for community services. But what arrangements are going to be made, for example, for the vaccination programme? And can you assure us that there will always be an NHS first preference and the private sector will only be asked to provide services as a last resort? Thank you.
Okay, we're including privatisation in this as well. Forgive us, Jan and John, for being broad, but I had Councillor Daunton next.
Yes, I'm actually coming back to my question about the voluntary organisations and where they fit into financing and the provision of services.
Okay, that's great. I'm also seeing Councillor Boulat, please.
Thank you, Chair. I had 2 themes which are separate, actually, concerns about privatization, accountability, and staff. So I'll just do all those questions at once because they are mixed. So on the staff, I think there have been some comments in some past discussions about potentially increasing capacity in the private sector if there was a need. So I was wondering, what are the plans to potentially increase capacity in the public NHS sector, and whether this was even possible at all, thinking or planning about this in the light of the national staff shortages. Again, I asked this question previously, but I was interested in the views in this group as well about whether the government's exemptions to social care visas actually helped. I got a bit of an answer in the last session, but I was wondering what the view is on that, because over 10%, as I understand, of the NHS staff comes from abroad. So I think it's a very important thing to speak about when we speak about resources and future planning. And I had a question which kind of crosses the staff and the finances, which is on the real living wage. So of course, as a joint administration, we focus focused on introducing the real living wage, so we made this a priority. So I was wondering at what point in this process of developing the new system we can think about implementing the living wage for staff that are not currently covered, because this kind of links into the recruitment and retention of staff, and especially younger staff, to enter this currently understaffed sector. And indeed, as Councillor Wilson said, there were quite many concerns about how this new legislation potentially could open up the way to privatizing some services. So I was wondering, what are the comments on this? What are the responses to concerns coming from the BMA and other health campaigners and experts on this topic, especially the concerns addressed at the national level? So what is our local response to that? So yeah, I have a few others about the kind of legal implications, but I think maybe they go on to the different themes. So I'll stop here for this one. Thank you.
That was plenty, but thank you very much, and all relevant. I'm going to add a couple. Like at the moment, we know that you're in SOF for the Strategic Oversight Financial Framework, rather, through no fault of your own, if I'm speaking personally there, that it's not about the services that are being provided, it's about the lack of finance that you're given to provide them. And to many of us, it seems unfair that you're in that position. But can we really launch a new ICS with chronic underfunding of the health service in Cambridgeshire and make it a success? You know, you have to, I know, but it's a proper question that, you know, does it form the basis that gives it a chance of being successful with such chronic levels of funding for our health service? And building on what Councillor Wilson said, you know, clearly there's the opportunity for us as a local authority to become a preferred provider, and there will be arguments for and against that, I'm sure, from the authority's point of view. But if we choose to do that, how will that be facilitated? Will you welcome it today as a possibility? Do you foresee it in any way? What would your message to us be about that? Are we a genuine partner in delivery and could take on that preferred provider status? Again, John and Jan.
Jan, do you want to start? You're probably closer to some of those than I am, but I'm happy to come back on other points.
Yes, so the first thing I think to say is, under the new ICS legislation, we are given more flexibility than we've ever had before on procurements. And so where it makes sense, where and it's in and it's part of core health services, whereas previously we would have had a requirement to openly procure that and open the market out. In the future, that is more restricted and gives us more flexibility in being able to use to think about how our local providers could provide that as and link it closer with other services. So what that basically means is we have more flexibility to ask our existing providers and voluntary sector, etc., to provide services without going out to the open market in the future than we've had to date. So I think that's helpful, because obviously every time we go out to a formal procurement, that is costly. But we do, within that, have to have a duty that we're still providing the care required. And I think that is partly why the voluntary sector is one of our biggest opportunities, is that actually it feels like, you know, the voluntary sector is quite, is quite a broad church, isn't it? You know, from your large scale charities to your small, individuals that volunteer on for very niche areas. So that kind of broad church, I think, is an absolute key part of our strategy. And if you think back to that end of life example, I think a couple of years ago we would never have even dreamt of saying to some of our charitable sectors, could you take the budget for this, and could you build a new service, and could you invent it, and could you do all the service users engagement, so that we could then get the best possible solution in place. So we're very keen to do that. I suspect we won't always get that right, but we're certainly committed to trying to learn how to do that. And I think, from working with colleagues like Will and Charlotte, they've certainly been able to steer us in some of that over on the health side. I think the notion of NHS first and privatisation, look, we have fantastic services in Cambridgeshire and Peterborough, and you know, and there are different levels of privatisation that exist. So what I've always said about this is, where we need to provide additional capacity to make sure we can get good access to services, we will not. We will always look to see where we can get that capacity from. And the best example of that is hearing tests with Specsavers. For example, if we're going to provide a block in audiology by sending everyone to a hospital, and we can provide that through a high street chain to make it really convenient for people in their local town to go and get, for example, their hearing test, and that's what we want to do. So I don't think it's as black and white as is it going to be privatised? Are we going to be selling off big chunks of the NHS and putting them under private organisations? No. Are we going to use those individual providers to make sure we get as best access as possible? Absolutely. And I think people would want that for convenience, speed of access, as much as anything else. So I think there is a balance there, but that is not privatisation of the NHS. I think, and that leads us to the part on workforce, which is, yes, we do have a chronic workforce issue. Yes, some of the flexibilities on visa exemptions have helped, but this is now about, we need to train more people. We need to bring more people in. We need to do a better job of retaining people, and we need to give people an even better experience, or a better experience of working in the NHS and care services, to make sure they want to stay and grow and thrive in those roles. And within that, therefore, we can, on the living wage question, we can push that as much as we like through our own services, but we also have to take accountability of the services we commission. And I guess that's an interesting question for Will and others, as we jointly commission services off a range of providers, say care agency, care home providers who might sit within that private bucket. How do we hold them to account for things like that living wage, and how do we do that more systematically? We have got financial restrictions. I happen to think, though, that we currently provide really good care. We are going to have to continue to make improvements. And the simple way to explain what we've got to do in our finances in real terms is, in 3 years' time, be spending exactly the same amount of money as we are now. What that means is we've got to make sure we are as productive as possible. And we know through the pandemic, we have lost some of that productivity because of infection prevention and control and other things. So we need to make sure we're as productive as possible to see as many people as possible. We need to make best use of our workforce. So if we've got a small group of highly qualified people that we're not getting to see as many patients as we could, we need to make sure that we are redesigning services to be able to open up those workforce to get more people seen. And we need to do a really good job in working with other areas that provide revenue into us to make sure that we are bringing that revenue in. And I come back to specialised services for that, because it's not just about our allocation and us being underfunded. We've got to bring income in to the sector. And as I previously said, the allocation that we get through health into the CCG, as it was, and into the ICB, is only actually a third of the total revenue that we get into health in Cambridgeshire and Peterborough. So we need to work hard with that as well. I think that covers the kind of broad brush of questions. John, what did I miss?
Well, I'll just add two comments. I don't think any of us involved in the conversations about the establishment of the ICS so far have thought about this in any way as a vehicle to think differently about the nature of who provides services in that sense. And as Jan says, it actually provides us with some opportunities to more flexibly commission some of our key partners in the public service. And indeed, when you think about some of those big things that we're talking about delegating to place, some of the anchor institutions that we're talking to about all of that very much are in the public sector. Richard, on your point, I can't, to the degree that an in principle answer is helpful, I can't see why one would in principle rule out the potential for any of our partners to be involved in those discussions as we go forward in the future, including local authorities. And on your point about resources, I mean, I think it's absolutely right that there's an argument to be made about the formula and about the nature of the funding that we get, and needing to point that out. And I'm sure we would welcome the chance to work together in terms of making those arguments. That won't solve problems in the short term, but we probably owe it to try and expose that issue over a period of time. Like you, like every local authority, I think our responsibility is still to strain every sinew to see how we can squeeze more out of what we've got. You've had to do that. We will have to do that because of the severe financial challenge we face. And we will continue to explore ways in which we can continue to provide the quality of care, but to do that in a way which takes account of the financial challenge we face.
Thank you, and absolutely commit the local authority to working with you on that joint advocacy role about funding, which is on behalf of the people in Cambridgeshire we jointly represent, so it's completely proper. Jan, can I just press you on Councillor Boulat's point though? First of all, it's the real living wage, which is Cambridgeshire County Council's priority. We have a policy to introduce it for all contractors, including care agencies and care homes, over a 3 to 4 year period. And that's not yet the position of the ICS. It clearly has financial implications, but in terms of joint commissioning, it has very clear implications if we're to enter into that. So I think, can I push you a bit more on that? And then in relation to what Councillor Boulat said, basically in the training, you said what you said today, more capacity could come from anywhere. If it's the right capacity, better meeting objectives, it could come from anywhere, and that includes the private sector. But what about increasing capacity in the public sector? Why not also commit to increasing capacity in the NHS and more direct services where new services are needed? You're silent on that, and it would be good to hear you on that.
So, absolutely, principally, the real living wage. I think I don't think any of us would have a problem if we committed to health inequalities, dealing with the wider determinants. Why on earth would we not be very committed to the commitments on the real living wage? And I'm certainly happy to have conversations outside of this to understand what your programme is and how you're doing that and what the impact is on the finance, so that we can go away and look at that and see how that could fit as part of our strategy. So wasn't trying to dodge that, just if we can get some more information on it, more than happy to take that and consider that at how we come alongside that. We are increasing NHS capacity all the time. I don't want anybody to think that we're just saying the only place for increase is private. That's absolutely not. But we do have some limitations, and that is primarily workforce and physical capacity in buildings, in some cases that are quite old, that we are trying to work through, and the capital programme that we're doing to support it. So we are constantly putting on more services through the NHS. So if I give you a few examples, we have put in additional primary care services, we have put in additional urgent care services, we have commissioned more services from the Ambulance Trust, for example, and our colleagues at our 111 provider. So every time we can do this and increase the capacity of deal demand, we are absolutely doing that. And we are looking to expand. The key bottleneck in it is actually workforce, because we have to expand and provide those services safely. And that's why the strategic workforce plan is so important for us going forward. But do be assured, I'm not deliberately staying silent on it at all. It's just, I must admit, I take that as a given that we are trying to expand what we can. But as I said, we need to make sure we're also as productive and efficient as we can, because more of everything won't necessarily solve some of the problems that we have today.
No, I think it's good to hear, and I think people will be reassured by that answer. But we encourage you to say it on other occasions too. Can I ask Councillor Every, what's the subject of your question?
Well, it's still on resources and finance, and but also your key point, Jan, on the workforce. And I know this is not the short-term problem to your long-term solution, short-term solution to your long-term problem. But we talked about local authorities. We haven't talked about the role of the combined authority and their skills committee, because the employment and skills strategy is out as we speak, and is being discussed again on Monday. This is place-based, and it's all about skills for the future, and one of the most important things is the careers programme that they have responsibility for. So I was just urging you, Jan, I'm sure you already are, but actually we have to start now with our primary schools and at the beginning of our secondary schools to make this kind of occupation attractive to our youngsters. We haven't done it successfully for years and years and years. And this is the only way you're going to get new staff. Otherwise, we're robbing Peter to pay Paul unless we're reskilling or upskilling. So it's really important. So it was just to urge, that this activity is carrying on at the moment with the combined authority, and that's where the schools service lies and the career service that's in schools. So I just thought I would mention that.
Thank you very much. Looking at the time, I'm going to have a sort of catch-all round now rather than theme it. So if there's a question you wanted to ask and haven't, as Councillor Every just hasn't, thank you. This is the opportunity to do it. Councillor Van der Ven.
Thanks. Could I just ask a follow-up question about the voluntary sector, who of course will not be represented at the ICB, the board table, as I understand it. And that's where sort of the hard questions of money, put it crudely, that's the table for funding in the big picture. So given integration and the critical role of the voluntary sector, who is going to champion their funding needs? And how are we going to resolve that matter? Everyone's going to be strapped for cash and we're going to be integrated. So where do they sit? How are we going to ensure that they have a voice at the table and that they are defended for the benefit of all, really?
Thank you. By the way, Councillor Gay has been with us for some time. I didn't welcome him because it was in the middle of a thing. If Councillor Gay or any of the other members online wish to ask a question, please don't hesitate to raise your yellow hand. Anyone else in the room at this point? It could be the last chance, so let's use it. Councillor Slatter.
Well, it's very much following up on what you had said, Councillor Hewitt. Some of my obsessions are teeth and nails, because those are often the things that people come to us as local councillors. Where can we find an NHS dentist? Where can I have my feet done or my mother's feet done? And these are, it seems to me, these do face barriers in NHS regulations. And I would seek some comfort from you that the ICS is going to be on the case when it comes to increasing capacity for dentistry and making it easier for people to get their nails cut in time before they cause other problems, because there are some fairly short-sighted regulations around that.
And looking around, I've got three more. The first one, John, as you said in your presentation, you're a local government person. Probably 20 years of your life you've been dealing with local government in one form or another, so you know what it's like to be us. Can you give your message to us, what you expect from us, what you hope from us? And you're bound, with great respect, you and all your colleagues are bound to give warm words about local government, and that's fine, but really what's our role in this? Convince us that it's not just warm words, if you forgive me putting the question in that way. Secondly, again, probably to yourself, John, but you made some really important points at the start about health inequalities, combating health inequalities, and how central that was to what we're going to do together in the ICS. We've got a brilliant public health team, and Jyoti Attry is listening to and participating in this debate on our behalf and on our joint behalf as an ICS. But is the system going to do more on health inequalities? Or in the end, is the system going to be doing what it does, and it's still our public health team doing its own thing, informing and advising, but not getting more support than it gets today? And I'm not saying it doesn't get support and coalition today, but the whole, I think, aspiration and philosophy of the ICS is that informs the whole system, not just the public health function. And finally, this point that again was raised by both of you in the introduction about the balance between acute provision and prevention. So everything we believe as a council, and I think everything you believe in all our conversations, is we need to shift resources to keep people living longer lives healthier, rather than to just deliver more and more acute health services more efficiently and better. But everyone believes that delivering it is damn difficult. convince the public watching this as well as ourselves that actually we'll make a difference on that. And again, it won't just be warm words, and that will transfer resources to where they will keep people living healthier lives for longer, because I think that's an important challenge to all of us. Jan and John.
So, Richard, my first go is that we'll convince people, I guess, by our actions rather than our words, warm or otherwise. So I recognise that. But I suppose put simply, I don't think we can succeed with any of our objectives unless we do work hard to bring about that shift and make that shift happen. And I think actually lots of our health partners, our acute trusts all the way through to other health providers, recognise that as well, that if there is to be a sustainable future for what we all care about, then we're going to have to do some of that. You said to me, what is it really, looking at you from the perspective of, I'm afraid it's a bit more than 20 years, would I say? I'd say bring all of the ways in which local government contributes to this to the table. It's yes, it's about public health, yes, it's about adult social care, but it's as this conversation has exposed this afternoon from the questions, it's about so many other things, and about how they contribute, I think, to the health and well-being of these communities over a period of time. So I think we will continue to badger you to say, bring all of that to the table, continue to challenge and to be honest in the way that you have been in our discussions up to now, and I have no doubt you will do so and continue to scrutinise, but also be an effective partner. So I think that's what we would be looking for. And as I say, I don't think we can succeed, or any of our health partners can succeed, unless we do bring about that shift over a period of time. Now, that's going to take some tough decisions, and it won't all happen easily or necessarily in all cases quickly. But I think we have to convince everybody that actually that's critical to our future. Jan, do you want to pick up?
Yeah, so I want to pick up the teeth and nails specific question as well. So I think what we need to remember is, this is all so interconnected that we need to make sure that when any one of us, if I can say, squeezes a balloon, that we really understand where that issue is going to balloon out. And I think in the past, if we're really going to get to a new way of working, then actually we need to do that across everything that sits within all of our remits. And so that's if we make a change to a voluntary sector agreement, whether we put in a new service, whether we take a service out, we really have to understand the impact and the wider impact on everything we're doing. I think when it comes to working public health, I mean, we have been investing in longer term issues. So we launched the BMI Can Do It campaign after the first wave of COVID, and a series of other things. So I don't want people to think we have never done anything on that. We've done that for a long time, and our diabetes programs, for example, and that leads on to cardiac disease, is also a good example of how that a lot of that is now on pre-diabetes. And our analytics teams works very closely with public health and effectively runs at one team, so we can get all of the planning a lot stronger. And when it comes specifically to teeth, I think I might have to pause on nails. I'm not sure I know enough about the nails, but I know about the teeth. I think, it's a really good example, isn't it? That, if we don't get dentistry right, then that could be really quite debilitating for people. But also people go to A&E because they can't get access to good dentistry. Currently, dentistry is actually run by the regional NHS England team, not held by the ICS. But actually, under the new legislation, it is another one of the accountabilities that will move from being regional to local. So we will become accountable for the provision of dentistry services. I think we would all expect to be slightly nervous about that, given that where it is now, it's not going to come down with additional investment to expand those services. So we are all going to have to work together to improve those dental services. And I agree, access to NHS dentistry is is really, really, really difficult for our residents. We're going to have to work together to say, how do we do that? Because when we take on accountability, it won't come with the money to expand those services. So we're going to have to do that very thoughtfully and carefully on that. And on chiropody, again, I don't know. I'd have to go away and find out more about the nails, but all of those areas like community pharmacy, dentistry are going to be moved from a regional provision to a local provision through the legislation in the coming years.
Thank you. I think, did I see Councillor Boulat's hand? So we have got just a few moments, so I will take Councillor Boulat.
Thank you, Chair. I'll try to be brief, and actually it's kind of a follow-up because it was asked before what was mentioned about the voice and the representation of the voluntary sector, because we speak about, the NHS often having staffing pressures and being, many people in NHS being overworked and needing more funding. But I think the situation is quite similar in our community and voluntary sector. And I speak as someone who, in my day job, when I'm not in council meetings, I work in the voluntary sector, in the third sector, on immigration type of services. And, we're very overworked and the funding is very limited. So I'm quite concerned in putting like additional projects. So I think we really have to look at how we fund this in a sustainable way and how to address some of the staff shortages as well in this voluntary sector that often supports healthcare needs as well. So I was kind of just following up on that. To what extent can we provide more representation and voice of voluntary sector organizations in this discussion? And just a very, very brief comment, if I may. There was a point about the anti-racism program, which I really do welcome. So I just want to mention that. So it'll be very interesting, perhaps another occasion, not in this meeting, to understand more about how communities can be involved in that program as well and how community voice is present there, because it's a very good development, I think. Thank you.
Thanks. On your first point, Councillor Boulat, this is to John and Jan. I think we also heard Councillor van der Ven's point about funding for the voluntary and community sector, particularly when, we've got one seat at a table, but that's quite a small minority in the board, but they've got no seats whatsoever. So they're asking also, will we be listened to? Will we get a fair slice of the cake and so on? And I think it's back to governance. We've not talked today about the relationship between the Health and Wellbeing Board and the Integrated Care Partnership. But as let's just put on record that we're working to make them as merged as possible, this committee in common principle. And I'd like to thank you for that, because that's the product of quite a lot of discussion and what's legally possible. But I think that's part of the answer about how we can make sure all of the consultation comes in. But I'd like to excuse me, to hear from you about all of that. So those 2 points, please.
So yes, and I apologise for not picking up Susan's point earlier. On the sort of governance point, quite clearly there must be a strong voluntary sector voice through the Integrated Care Partnership. It's important that we have that. And of course, the partnership has got to shape the strategy. And as you say, Richard, we're trying to make that as aligned as possible with the Health and Wellbeing Board, which the Integrated Care Board will be charged with delivering. The board itself, of course, has to be a slightly smaller gathering, but also is a unitary board. So there will be quite a lot of partners, who are not represented as institutions around that table. But I do draw a distinction between meaningful participation in this partnership and driving the strategy and who sits necessarily around the board table. And we've got to, I think, continue to strive to make sure that that's real. So we haven't absolutely finalised on any of these things in governance terms, but we must have a strong voice for the voluntary sector through the Integrated Care Partnership. That must translate itself into the strategy that we develop, and which the board, the unitary board, then delivers. That won't entirely satisfy everybody. I recognise that, and people will always want to be around tables. But I think there is a difference to being a sort of strong participant and necessarily sitting at the table. Jan, anything you want to add?
I think that covers it. John, thank you.
You shocked me there, Jan. You're very eloquent and you didn't add anything. It gives me a few moments then to sum up what I think has been an excellent session. I think Councillor Murphy talked about constructive challenge, and this afternoon's questions have been in a spirit of constructive challenge. I hope that's how it's appeared to you. It's certainly how we intended it. And I think we've illuminated a lot of issues, and I think your spirit in response, I'd like to pay credit to and say thank you very much, not just for today, as always. Your opening, John, where you talked about being committed to a population health management approach, tackling inequalities, building in broader economic and social development to health objectives is absolutely where we stand. And so we strongly support you and strongly want to work with you to achieve those objectives. When we talked about lines on maps, I think, Jan, your point about the commitment to subsidiarity, as properly defined, is absolutely fantastic. And certainly in what we've said to you about governance, that's what we've asked to see. And we've heard from district members how much they support that, and even districts are not neighbourhoods. So how far can we really drive this? And everything that you've said about people, both of you have said about people seeing seamless, joined up services that are closer to them. These are absolutely the right aspirations that this authority supports. We have been reassured, I think, by what's been said about safeguards against privatisation, the commitments you've made against sell-offs to say that capacity is being driven up within the NHS. I think are really important things for people to hear. Your openness to what this authority is doing on the real living wage, thank you for that. And we would certainly want to follow that up. John, your point about underfunding and cooperating together in joint advocacy, better and stronger to get a better, frankly, package and for Cambridgeshire, we absolutely want to be your partners in that, and let's turn that into practical actions. We've had very interesting points about the workforce and collaborating together on the workforce. The old thing about the NHS was isn't it the biggest employer after the Chinese Communist Party? But I don't believe the Chinese Communist Party has got many members in Cambridgeshire, but that 1 in 25 figure is a really interesting figure in a different way that we can mobilise it. So I think you made a really important point there, Jan. On what the local authority can bring, those messages you gave to us are heard. It's a particularly good challenge to say, bring all local government services, not just the ones traditionally orientated towards you. It's a great challenge back to us. As you know, we've adopted as a new administration the World Health Organization Health in All Policies approach, and we're challenging our own authority in that. And so I think we're going to have some very good answers to you in relation to that. What you said about using less competitive tendering where desirable, Jan, and really advancing and developing your relationships with local partners, and the commitments you've both given to the voluntary and community sector, I think are again really important messages to come out of this afternoon. And we've both talked on the councillor side as well as your side about real alignment in terms of the ICP and the Health and Wellbeing Board, and it's great to get those developments and our joint commitment out into public on that. I'm sure I haven't done justice to some of the things said, but I've hopefully have summarised some of the key conclusions. And normally when we're scrutinising new developments, we say, will it have teeth? And we've talked about teeth. So it will have teeth, but when it, thank you. I've got some groans in this room if that didn't come through on the microphone. But hopefully those issues about democratic accountability, the role of the Health and Wellbeing Board have teeth, as well as the services having teeth. This is the latest of a series of conversations that will continue between us, but it is one that we put on record for the public of Cambridgeshire, our electorate. And as we said in preparing this meeting, for a major reorganisation of the NHS, for us not to undertake this scrutiny function would have been remiss. And so for very busy people at a very critical time in terms of the pandemic, we can't thank you, Jan, and you, John, enough for committing time to the issues and the discussion that we've had this afternoon. It does conclude the meeting for today. Our next meeting will be on the 17th of March Thank you to our district members who've joined us online. Thank you to all the members of the room. And I announce, with thanks again to John and Jan, the meeting closed.